Sundaram, Head Department of Neonatology, and Dr. L. Subramaniam, Head Department of Pediatric Pulmonology. We fondly refer to them as Trinity or the Trimurti, who are responsible for starting the Department of Pediatric and Subspecialties in Dr. Mehta's. The seed they have sowed has now grown into a huge banyan tree, yielding fruits in the form of students who have now become faculties. So our salutations and welcome to Dr. BRM sir and Dr. Shanmugh Sundaram sir. A very warm welcome to our own Professor Dr. Edwin Fernando, the ever smiling, ever young, dynamic person who motivates all of us into greater heights. A very warm welcome to you, sir. Our very warm welcome to Dr. O.P. Mishra, President, Indian Society of Pediatric Nephrology, Madam Dr. Rama Chandramohan, President, National Neonatology Forum, Tamil Nadu Chapter, Madam Dr. Elarasi, President-elect, Indian Academy of Pediatrics, Chennai City Branch. On behalf of Dr. Mehta, we welcome you all, Madam. Finally, our dynamic Vice Chairman, Mr. Sameer Mehta, who pushes us and goes us to greater heights, who is dynamite behind all our efforts. A very, very warm welcome to you, sir. As the Upanishad says, let us all proceed from ignorance to light, from knowledge to wisdom, from mortality to immortality. Let this program infuse great knowledge in the minds of all the delegates. My warm welcome to all the faculty, and my warm welcome to all the delegates. Let the knowledge and wisdom we cull from this program be of useful to the wonderful children we treat. Thank you very much.
A brief introduction of the program. So this neonatal nephrology update was envisaged by, and the idea was first given by Dr. RSS. He's joined us today. This aims to address the issues pertaining to kidney disorders in utero and in the neonatal period. We have excellent faculty from India, Europe, UK, and North America. We have received more than 1,200 registrations so far, and predominantly from Asia, India, North America, and South America, but really this thing is widespread. There's been plenty of pediatricians, nephrologists, and neonatologists who have shown interest in our program. These are our faculties, and we are really, really grateful for them to have joined. We have the team neonatology here with us, and it's a really, really a robust team with a very well acclaimed fellowship program and a very busy unit. We have our own pediatric nephrology department, again, one of the largest private dedicated unit in the city for children with kidney disease. We frequently collaborate with many, many centers for academics and for research purposes. And our current faculty is Dr. Sudha Ekambram, Dr. Kalaivani, and myself. Moving on, I would like to welcome a beloved Vice Chairman, Mr. Sameer Mehta. He's a person with many, many credits to his name, more than what I've listed here down. The Mehta family, including our chairman, Mr. Dilip Mehta, our vice chairman, Mr. Sameer Mehta, and a director, Dr. Pranav Mehta, have all been pillars of support for academic programs like this, and especially Mr. Sameer. He himself has conducted many, many acclaimed high-impact academic programs, more so during the pandemic. And he remains a staunch supporter of these programs. We are very happy to have you with us, Sameer, and really appreciate you taking time to do this. We know you're extremely busy. Mr. Sameer, please.
Thanks a lot, Dr. Suganya. So it's great to see the what I call the League of Legends. And I actually extend that to all of you, both participants, faculty, and the folks that your families, because at the end of the day, your families also enable this. And I think that's what Dr. Mehta's really stands for. We believe in bringing people together to make the world a little bit better in our own way. And clearly, with our legacy of now 88 years, entering our 89th year of service, we have always valued what our grandparents gave down to us, which is keep a stronger family, make sure the values stay the same. But at the end of the day, what really makes the difference is customer affection. If you care enough for your customer to go above and beyond well after 12 at night, you will look after it. And that is something we've seen embodied in the many leaders that stand here, from Dr. RSS to Dr. Namalwar, Dr. Sukanya, Dr. Sudha, Dr. Kalevani, and friends like Dr. Edwin and Dr. Kannan, because after a while, family and friends are a very thin line. Uncle Eddie, as we've now nicknamed him, nothing to do with once upon a time British ski legend, or I think he was Canadian or British. I never remember what the very famous ski jumper was. But I think that's what this represents, bringing people around the world together to teach, to share the best practices, and to go one step further. You're doing this so that we as a collective get better, irrespective where in the world we sit. And I think what COVID has taught us is that what happens in one nook affects the other corner of the universe, whether we like it or not, whether we love it or not. Whether you love the old soaps series of in the yesteryears like Dallas, or I should pick something like Coronation Street, because we've got our friends from the Great Ormond Street out here, or the ones I used to love out of the UK, the Upper Hand and stuff. Those were the positive, happy things where countries shared in very concentrated manners practices to other parts of the world. Today, what you see is from every nook and corner, we need to share more data. We need to get the collective wisdom of the world smarter. And I think it's in that interest we welcome you. We hope you join our Dr. Mehta's family in some form, helping, whether it's a small hospital somewhere in India, whether it's a really small hospital somewhere in England, or whether it's a dynamite big metro setup somewhere in Argentina or Spain, Australia, Africa, it doesn't matter. This is one world. We beat with one type of blood. We have many strands, but at the end of the day, it is still red blood, right? Now, I'm sure that somebody's going to tell me off because they've also shown me different color blood sometimes, but I like to think about it as we are one world. So I think with that, welcome. I hope you learn from each other. We hope you enjoy the privilege of sharing time with legends like we have. And I think it's great to see Dr. Namalwar. I hope I get to see Dr. RSS and many of our forefathers, because they are almost like people like my dad who helped teach in the generations that we stand on the shoulders of these giants. And I think Dr. Suganya, many of you and your team of faculty stand on the legends that once stood before us. Whether they're inside Dr. Mehta's or beyond, it doesn't matter. As long as we can all learn together, I think the world's a better place. So welcome.
Thank you. Thank you very much, Samir. And thank you very much for joining. As Mr. Samir said, both the departments of neonatology and pediatric nephrology are very fortunate to have such stalwarts as their mentors. And we, time and again, they've seen us through so many accomplishments. Dr. RSS, the founder of neonatology, particularly at Mehta's, he's not a very public person. So sir has asked me to convey his blessings and his best wishes for this program. We have Professor Namalwar with us. He's the Director of Pediatrics and Pediatric Nephrology. He's also one of our founding fathers for neonatology, for pediatric nephrology. He's mentored in numerous pediatricians and nephrologists all over India. He's widely regarded as a global icon. And Professor Namalwar, sir, if you could say a few words. So, sir's there.
Good evening to all of you. I'm indeed proud, and it's a great privilege to be part of this neonatology nephrology update. I'm so happy to hear that Dr. Sukanya has done an excellent work in organizing things, which is not strange to her. She's always a good person who can organize things and well planned. I wish her all the good luck and things. I'm happy to invite all the participants and the faculty to this update. I wish them all good luck and things. I hope at the end of the day you'll have a very good, enjoyable and useful academic performance. Thank you very much, Dr. Sukanya, for this invitation. Thank you to all of you.
Thank you. Thank you very much, sir, for joining. Dr. Edwin Fernando is the head of the adult nephrology unit here at Mehta's, and he also heads the nephrology unit at the prestigious Stanley Medical College. We work very closely with him, and his time and again, he's given us his expertise, especially in the field of renal transplant and academics. Dr. Edwin, please.
Thank you, Sukanya. It's nice to meet all the legends here. In the interest of time, I shall take this opportunity to thank Samir Mehta for all the support and encouragement he's been giving for all academic activities in this hospital. Rukhsana Shroff, who trained Sukanya to be with us. We thank all the support systems for this meeting, the Neonatal National Neonatal Forum, the ISPN, the IAP, the IPNA. All of them, thank you all for sharing this responsibility to take the knowledge of neonatal nephrology, which is a totally different ballgame compared to the adult patients that I see. So with this short, and I was always place my appreciation for Dr. Sukanya for putting together this very nice program. We had a lot of glitches in between, and I'm happy it's through. We have 2 days of 6 hours of virtual sessions and 1 practical hands-on session on Sunday. And I thank all the faculties, and I wish all the delegates happy learning over the next 2 days. Thank you, Sukanya.
Thank you very much, Mr. Edwin. As you all know, we are supported by the International Society of Nephrology Sister Renal Center program by Great Ormond Street. This program is a combined effort of both our units, and been very, very fortunate to be mentored by Rukhsana Shroff. She's been the backbone of this program from day one, and even before this program, and over the past few years, she's been a huge support, and we have learned so many things from her in the last few years. I've personally gained so much from the collaboration with Rukhsana. But today it gives me immense pleasure in introducing her as a freshly minted professor of pediatric nephrology at Great Ormond Street Hospital and University College London. Rukhsana, many congratulations on that professorship, and please would you like to say a few words?
Thank you very much, Sukanya. So friends, our story goes back to 2017. We had a shy young lady who came to us on an IPNA and an ISN fellowship. Many people didn't pay much attention to her because she stayed in the background. But very, very quickly, we realized that she learned like a sponge. She absorbed and assimilated everything and moved from strength to strength. And even in the short 6 months that she was with us, she was a specialist in so many skills in pediatric nephrology. This is Sukanya Govindan. It's my great pleasure to be her mentor. She has moved from strength to strength, and with the support of the Mehta Multi-Specialty Hospital, her esteemed colleagues who are all here today, Uncle Eddie, and a vast network of friends, family, and supportive people, she has excelled in everything she does. She takes no credit for it, but she deserves all of this. Sukanya, well done. You are really a rising star, and you've gone from strength to strength. Well done on putting together this fantastic symposium. Now, pediatric nephrology and neonatology are relatively young fields in the scheme of things in medicine, and both have kind of worked in parallel but rarely come together for specialty meetings. And it is this wonderful occasion today where we bring together neonatology and nephrology to discuss together the issues we see in each specialty, and to together share knowledge and become stronger for the sake of our patients. So without any further ado, Sukanya, well done again on this wonderful conference. Thank you for taking us through it. And I hope that everybody has a very good learning experience over these two or 3 days. Thank you.
Thank you, Rukhsana. I've been too generous, and the webinar has had an amazing response so far, and it could not be possible without the help of the endorsement and support of the International Pediatric Nephrology Association, the Indian Society of Pediatric Nephrology, the National Neonatology Forum, and the Indian Academy of Pediatrics. We're very grateful for their endorsement and their help in sharing this program widely. On behalf of the Indian Society of Pediatric Nephrology, we have the President, Dr. O.P. Mishra, The Indian Society has kindly helped us with so many programs, especially from Mehta hospitals. They've been a great support. Dr. O.P. Mishra, if you'd like to say a few words, please.
Yeah, good evening to all of you. At the outset, I express my sincere thanks to Dr. Sukanya and her team, Mr. Mehta, Dr. Kannan, Dr. Namalwar sir, and others, and faculty from overseas and India who are going to participate in this 2 days academic fest on neonatal nephrology, covering various aspects. And that on day 3 hands-on session, and this type of session really encouraging for all of us. And it is a good learning exercise, especially for youngsters working in the field of pediatric nephrology, including neonatology. So I extend my best wishes on my behalf as well as on behalf of ISPN to have a grand success for this program, as being the apex academic body in the field of academic pediatric nephrology. We support and we think that it should further progress day by day, year by year. Thank you very much, Dr. Sukanya, for inviting me for this brief introduction, and my all the best wishes to the academic program. Thank you very much.
Thank you very much, sir, for joining today, and thank you for speaking. Next, we have representing the National Neonatology Forum, we have Dr. Rema Chandramohan. She's the president of the Tamil Nadu chapter. There's been a wide and very good response from the neonatologists showing how eager they are to learn and how few opportunities have been had to discuss these topics. So we have Dr. Rema Chandramohan with us. Dr. Rema, would you like to say a few words?
Thank you, Sukanya. Good evening to everyone here, my teachers and colleagues. I'm extremely pleased to be part of this program and representing NNF Tamil Nadu, partnering with Dr. Mehta's. As has already been told, neonatal nephrology is a budding specialty. We know that neonates are compromised in several ways, and most of the time the brunt is borne by the kidney. And more so now we see when these VLBW, very low birth weight and extremely low birth babies are being delivered and are being salvaged. We need to know all the more about the fluid and electrolyte balance, and we need to know that they have to be kept in tight range so that these babies can come out with an optimum outcome. And not only that, we see a lot of babies succumbing to acute kidney injury, which if missed can result in permanent damage. And the third thing that we are going to see, that we see right now, are all these congenital malformations which are picked up by the ultrasound, which earlier would have been missed and would have resulted even in a stillbirth. These babies are surviving now due to some therapies which are done in utero and some which are done post-term or post-natally. And these are some things which can resolve also. So we should be prepared with adequate knowledge so that we can prognosticate to the parents as to what to expect. So I think this conference has been planned with all these things in mind. So anybody who's attending this conference, whether they are pediatricians or neonatologists, are going to have a very good idea about management, starting from the basis of GFR, which I'm seeing in the group. All the topics have been very carefully chosen. The speakers have been handpicked, and I'm sure that there's going to be a very great learning experience for all the delegates here. I wish the organizing team, Sukanya with the lead, and the delegates and the faculty a fantastic learning experience. Good luck to all of you.
Thank you, Dr. Rema. Finally, we have our very own faculty, Dr. Edla C. She's representing the Indian Academy of Pediatrics, the Chennai City branch. She's the president-elect, a very charming and a youthful person. Dr. Edla C, please, could you speak a few words?
Thank you, Sukanya. I had to step in because President Dr. Venkatesh is out of town. It gives me immense pleasure. It's being a part of Mehta and to represent CCB. Pediatrics was so fascinating 30 years ago. Neonatology and nephrology, per se, two different departments, have really fascinated me. But getting them both together, neonatal nephrology, I mean, it sends goosebumps to me. This is not what we would have dreamt of 30 years ago. And with stalwarts, my mentors, Dr. B.R. Namalwar and Dr. RSS, I'm sure they're grandfathers of neonatology in probably the entire South India, or I would say India, and nephrology. will be very happy today when we are going when their grandchildren, I would say, because we are the second generation after them, and now Sukanya, Sudha, and Kalaivani have taken over. So they would be very happy to see the progress of these, bringing in both the specialities of neonatal and nephrology together. And I am sure Dr. M. Vijay Kumar would be moving in his grave with happiness. Sir, I hope you are very happy with the progress that we have made. And I thank Mehta. Mehta has always been a very academically oriented institute, and they've been doing a lot in spite of the corona. They've been doing a lot of academic sessions. I congratulate the nephrology and the neonatology team of Dr. Mehta's, and I convey our best wishes and good luck from myself and from IAP's CCB. I'm sure we are all going to have an excellent academic feast over the weekend.
Thank you. Thank you very much, Dr. LRC. So now we are coming to the end of this inaugural session. We are slightly 5 minutes behind schedule. But before closing, I would like to thank all the faculty. The faculty are the strength of this program, and whoever has joined today and who will be joining tomorrow, as well. I really appreciate you taking the time to join us and deliver your lectures today. We know you're in different time zones. We really appreciate you for the effort. From here, I would hand on the proceedings to our fellow, Dr. Pooja. She's an amazing, smart and young pediatric nephrologist. So Pooja will be doing the proceedings from here. Thank you.
Thank you, Dr. Sukanya. A very warm welcome to all of you. Without much further delay, we will proceed with our scientific session. And before starting with the session, I would request all the delegates to kindly post their questions in the Q&A box and not in the chat box. And these questions will be taken at the end of the session. I would also like to announce that the telecasting platform will be redirected to the YouTube live streaming in case we cross the full capacity, and the delegates can post their questions in the comment box below. So our first session for the day will be on renal function and acute kidney injury. And this session is being chaired by Dr. Arpana Iyengar. She is currently the Professor, Department of Pediatric Nephrology at St. John's National Academy of Health Sciences, Bangalore. She also holds various posts currently, being chaired ISN Clinical Research Program, liaison officer ISN Sister Transplant Centers between Bangalore and Rome. She's also a subject editor, ISN Academy, executive committee member, ISN South Asia, and core committee member of ISO WHO. She is a nephrology specialist member among various committees such as ABM Jan Arogya Yojana and National Health Authority of India. She's also a member of editorial board among various journals. And I would like to hand over to Dr. Arpana.
Thank you, Pooja. Good evening, distinguished international faculty, national faculty, colleagues from Mehta Hospital, and dear delegates. And a special congratulations to Dr. Ruxana Shroff from my side for another feather in her cap. It is indeed a pleasure to be here on a very unique forum of neonatal nephrology that is seldom under the spotlight, especially in this part of the world. We shall kickstart the first session on renal functions and acute kidney injury in the newborn with 3 lectures followed by a dedicated time slot for interaction between the audience and the speakers. May I now invite the spearhead herself, Dr. Sukanya Govindan, to deliver the first talk. Dr. Sukanya is a consultant pediatric nephrologist at Mehta Multi-Speciality Hospitals, Chennai. She has received training from prestigious institutions like JIPMA Pondicherry, PGI Chandigarh, and Great Ormond Street Hospital for Children, London. Dr. Sukanya holds a keen interest in pediatric AKI and neonatal AKI, and she has organized many skill-based workshops especially in the field of renal replacement therapy in the region, not only for pediatricians, but also nurses and technicians. So we look forward to your talk on GFR assessment tools in neonates and hope that you will solve the creatinine conundrum in the neonates for us. Over to you, Dr. Sukanya.
Thank you very much, Dr. Apna, for the very kind introduction. We're really, really happy to have you today. Let me just share my screen. Yeah. Yeah, sorry. Is it visible now? No. Just get me a minute. Just a second. Just I'm not able to see Zoom here. Yeah, sorry, very sorry. Yeah. Thank you very much. It's just a lag. Yeah, very sorry for that. So let me start quickly. Yeah, so the topic that I would be speaking on is glomerular filtration rate in neonates. And it's one of the most, this topic has many difficult questions and tough answers. And moving on, this is what we will be discussing in the next few minutes. Kidney maturation, a few words on how GFR kinetics works in the fetal period and in the neonatal period. How do we estimate GFR? And what are the clinical applications of GFR that we would do? Moving on to kidney maturation. Kidney maturation, as we all know, is a very complex process. What starts as just two cell lineages in the ureteric bud and the metanephric mesenchyme sort of matures into a nephron with more than 25 different types of cells. In the level of the glomerulus, there is integration of the mesangium, the podocytes, and the endothelium. And after the glomerulus, the tubules undergoes a few processes like nephron patterning and mesenchyme to epithelial transformation before we get a full mature nephron with different types of cells. This is the nephrogenesis timeline. Nephrogenesis starts as early as 5 weeks of gestation. But however, the first glomeruli are formed at around 9 weeks, where you have this S-shaped vesicle being formed. By 10 to 12 weeks, you have urine production, which contributes to very little to the amniotic fluid at that point in time. But however, by 20 weeks, we have accelerated nephrogenesis, wherein your glomeruli start forming, looks like this, and there is multiple ureteric bud branching. At this point in time, the fetal urine is around 5 ml per hour, and it contributes to almost 90% of your amniotic fluid. The nephrogenesis process by which new nephrons are formed is stopped by 35 to 36 weeks. This sort of continues into the postnatal period only in extreme preterms. Otherwise, most of us would have only the number of nephrons that we have when this nephrogenesis process is complete. At this point in time, the fetal urine is almost all of the amniotic fluid. Just a bit about the glomerulogenesis stages. The glomerulus, you can see that there are many stages to the glomerulus. From what is an S-shaped renal vesicle, it becomes into a mature glomerular unit with multiple differentiated cells, the fenestrated endothelium, mesangium, and podocytes. But this process of glomerular maturation is at once, it's asynchronous, meaning you can, in the same kidney, you can see different stages of glomerulus at the same time. And also you can have a centrifugal maturation of the glomeruli, meaning the superficial glomeruli are very mature and the deeper ones are mature. Postnatally, there is maturation still happening, but all this maturation is not an increase in numbers, but rather an increase in the glomerular size. And also with the more mature and well-formed capillary loops, there is an increase in the filtration surface area. And there is recruitment of all the nephrons, starting from the deeper to the less mature superficial nephrons. All these, along with alteration renal perfusion pressure due to an increase in cardiac output that the kidney receives postnatally, contribute to postnatal maturation and increase in GFR. So this in prematurity, the nephrogenesis sort of continues till at least 40 days after birth, and this is especially true in extremely preterm infants. A little bit about GFR kinetics. GFR as a thing is being governed by various factors. Of important factors are this net ultrafiltration pressure, which is the difference between the hydrostatic and oncotic pressure at the glomerular capillary level, the rate at which the plasma flows into the glomerular capillaries, which is mostly influenced by the cardiac output that the kidney receives, and the ultrafiltration coefficient, which is linearly related to the permeability and the filtration surface area of the glomerular filtration barrier. But in practice, what we measure as the GFR is the total GFR, which is the sum of single nephron GFRs of all the functioning nephrons in the kidney. So if you have 10 nephrons, each contributing 10 mils per minute of GFR, you have a kidney which totally gives you 100 mils per minute of GFR. And the single nephron GFR is given by this formula. Just to explain what all govern the working on either side in the glomerular capillaries and in the Bowman space, and they are opposite to each other. Finally, the ultrafiltration coefficient, which is directly related to the glomerular filtration barrier's permeability and surface area. The surface area sort of influences this more compared to the permeability after a point in time. So we have something, the GFR sort of gives a sigmoid hyperbolic curve like this. So what is very little here in the fetal life sort of increases rapidly. This is the time around we reach the completion of nephrogenesis, 35 to 36 weeks, and it quickly starts maturing with the most rapid gain seen in the initial 2 weeks of life. After that, the GFR sort of steadily but surely rises and reaches adult levels by 2 years. There are many things that help with this postnatal transition. The most important one was probably the structural changes that happens immediately after birth, which I've already explained. These changes sort of also accommodate an increased renal blood flow, and also there is a decrease in the renal vascular resistance. There are also several vasoactive factors which determine how good our GFR maturation is going to be. The angiotensin II is probably one of the most important of these. In the neonatal life, it sort of gives a preferential efferent arteriolar constriction, thereby maintaining GFR even at very low renal blood flows. The prostaglandins, as such, the neonates have a higher concentration of prostaglandins. This is very important for autoregulation in the neonatal period. Also goes on to explain why they are so finicky with drugs like indomethacin. The neonatal GFR is sort of highly dependent on this balance because the autoregulation is yet to mature completely. There are several other vasoconstrictors and vasodilators, including glucocorticoids. Glucocorticoids increase in the maturation of the sodium-potassium ATPase pump and sort of increase the sodium reabsorption and increases the effective blood volume. There are many more effects to glucocorticoids, but they are not very well defined as of yet. So finally, we have something like this. So we have a low renal blood flow status with low cardiac output, with the high vascular resistance and a low mean arterial pressure. So we have a GFR of something like this at this point in the fetal life. So in the postnatal transition, we go on to an increased renal blood flow state with a cardiac output of 8 to 10% at birth. There is low vascular resistance and high mean arterial pressure. Slowly, this improves and the GFR doubles by 2 weeks, reaching adult levels by 2 years, by which time you have a cardiac output of almost 25% to the kidneys. This process can be hampered by many different factors. In the fetal life, maternal hydration, placental insufficiency, and drugs can impair this GFR rise, whereas postnatally, prematurity, low nephron mass, birth asphyxia, sepsis, and drugs like NSAIDs and angiotensin converting enzyme inhibitors can sort of influence this postnatal maturation, and preterm infants, especially the extreme preterms, sort of their GFR curve is blunted and it takes even up to 8 years for them to reach adult levels. So how do we measure GFR? So GFR, as I said, it's dependent on the single nephron GFR, and it's really difficult to actually put in an electrode in each one of them and measure the GFR. So in clinical practice, we use solutes, which are predominantly handled by kidneys, and use them to assess or measure GFR. One of the well-defined and well-studied exogenous markers is inulin. It is inert, completely filtered. It's neither reabsorbed or secreted into the tubule. Sort of, it's the ideal marker, but it's really, really cumbersome to use this because of it requires IV infusion, repeated plasma and urine sampling. The other radionuclide studies that we routinely use in bigger children and in adults are not validated yet in neonates. They're also poorly taken up by the immature kidney. So we clinically use probably only endogenous markers like creatinine, urea, and cystatin C. They are practical, they are easy to measure, and markers like creatinine are the most cost-effective ones that we have. But they are influenced by various factors, including tubular handling and patient-related factors. Creatinine is probably the most widely used endogenous marker. It's derived from muscle in the neonates and meat in diet from older children. It's completely filtered, and it has some component of tubular secretion. It is influenced by many non-GFR markers, most importantly, muscle mass, protein intake, and metabolism rate. All these differ very widely in neonates. Of particular importance in the neonatal period is the reflection of maternal values in the immediate postnatal period on the baby's creatinine. And extreme prematurity sort of decreases clearance of creatinine and has premature infants have a higher creatinine value. There's also a wide variability in the GFR for a given creatinine. A creatinine of 1 milligram could mean anything from a GFR of 20 to almost 90%. And also creatinine is a very, very late marker, meaning it does not rise before there is a 50% loss in your nephron mass, which makes it not really very suitable for monitoring. There are various assays available. Calorimetric assays are still probably the most commonly used in several parts of the world, but slowly and steadily we are making a change towards enzymatic assays. These enzymatic assays are now traced to the isotope dilution mass spectrometry. Even with these methods, creatinine continues to be a less sensitive marker when GFR changes. For small GFR changes, the sensitivity increases, however, by if you add on urinary creatinine clearance. But as we all know, urine collection is a headache in neonates. But clinically, what one could do is due to repeated measurements to sort of increase the accuracy of creatinine. We also have, this is a chart which shows how the GFR progressively increases across different gestational ages and different weeks of postnatal age. You can see there is a steady increase across all gestational ages, but if you see the creatinine, it's sort of up and down. So why does this happen? In the initial few days, it sort of reflects the maternal values. There's also back diffusion. We saw that tubular secretion is there in for creatinine. That is how it's normally handled. But in neonates and extreme premature infants, there is also this back leak, sort of it's reabsorbed into the tubules. So there is back diffusion accounting for an increase in creatinine in the initial days. So moving on to cystatin C. So we know that all is not well with creatinine. So we more recently, there are many studies using cystatin C. It is a proteinase inhibitor produced by all nucleated cells. It's freely filtered, completely reabsorbed and catabolized. So it does not come out in the urine in the normal state. It has a shorter elimination half-life, lesser than creatinine, so that it can rise quickly when there is kidney damage, even before creatinine. However, it is influenced by inflammation, steroids, and thyroid function. It offers greater sensitivity while detecting an abnormal GFR in neonates. It does not cross the placenta, so it's very valuable in the initial few postnatal days. It slowly decreases to reach adult levels by 1 year of age. However, the assays for cystatin are not widely available. A newly recognized protein for GFR marker is the glycosylated protein beta trace protein, which is present in various fluids in the body. It is particularly gained importance because of its non-renal interferences and no interferences with inflammation and steroids. So how does creatinine and cystatin C fare versus each other? So this is a longitudinal study which has looked at the maternal serum creatinine and the cystatin C, and also followed up term neonates creatinine and cystatin C over the first month. If you see, the creatinine has such a huge variability over the month, but it also steadily decreases, whereas cystatin C sort of drops in to a baseline by day 1 or 3 and then sort of remain stable. So telling that cystatin C in normal neonates is sort of stable, and any fluctuations could indicate kidney damage. Also, cystatin C performs better in children with low nephron mass. This study done in 2012 sort of looked at patients who did not have any kidney malformations versus patients with unilateral kidney malformations and bilateral kidney malformations. And this is the delta cystatin C that happens. So if you see the children with lowest nephron mass have the biggest change in cystatin C, this sort of indicates that even when there is less than 50% nephron mass loss, where creatinine tends to be the same or not or unchanged, cystatin C is a better marker to see if there is ongoing kidney damage. So what do we do with these values of creatinine and cystatin? We use them to estimate GFR and arrive at a value of GFR. Are there equations, however, for the neonatal period? The answer is very sadly no. The best equations that we have and the most commonly used are the modified Schwartz formula, the Conahan's formula, and the Flanders metadata. So this table sort of gives the age range in years. So the postnatal age of 1 month corresponds to 0.083 years. If you see this table carefully, only the Flanders metadata sort of comes closely to at least 1 month. So we yet do not have a validated formula for use in neonates and in especially preterms. There's also the cystatin C based formulas here. None of them have been validated yet in neonates. So this is a very, very sad thing. So in clinical practice, we use the Schwartz formula, which is now the modified Schwartz formula, or the full CKID formula, which is tested in children between 1 to 16 years of age. And it's given by this formula. The Flanders metadata equation is also fares very well in young children, especially less than 6 years. These are the few things that we have now for estimating GFR. So what do we do when we have insufficient tools or improper tools to estimate? There are some strategies I would suggest to improve accuracy. Urinary creatinine clearance, as I said, is difficult to measure in neonates. We should be using repeated measurements of serum creatinine, and also, if possible, and if it's available, use a combination of markers like creatinine and cystatin C. Both together in combination fares very well, even compared to cystatin C alone or creatinine alone. And cystatin C should definitely be considered in infants with low nephron mass. We can also use surrogate markers of early kidney damage, like using proteinuria and blood pressure, which is freely available across many centers in the world. So what are the clinical applications of GFR? Till date, GFR remains the best marker of kidney function. We use it to anticipate complications both in the short term and long term. We use it to establish prognosis for staging of kidney disease. We also base our treatment decisions like drug dosing and renal replacement on GFR. The staging of kidney disease, which traditionally is given by the KDIGO stages from 1 to 5, does not apply to neonates or infants less than 2 years because they do not reach adult GFR values, and hence the classification becomes mute in them. We sort of use age-associated creatinine clearance or radionuclide GFR that we've got, and usually use the terms moderate reduction in GFR or severe reduction in GFR based on how they fall between which standard deviations they fall. Moving on to drug clearance, we know that 60% of all drugs are actually cleared by tubular secretion through either organic anion or cation transporters. But in practice, we use GFR to actually assess the renal clearance, which is really doesn't fit. So if you see, only few drugs are being handled by GFR, especially the low molecular weight drugs. Majority of drugs are lipid soluble and are more polar, so they are handled by the tubules. So we are already using a very improper method to assess drug clearance and for drug dosing. And sort of low GFR in infants also impacts absorption, distribution, metabolism, and non-renal clearance. However, very recently, this study is published. It looked at how glomerular filtration predicts tubular secretion in a stable state in adults. This study shows that glomerular filtration is a good predictor, at least in stable patients, both without CKD and with CKD. But however, whether this could be extrapolated to neonates or children remains yet to be seen, and whether this is the same in other disease states like acute illnesses remains to be seen. So I had to look at what are the common neonatology references for drug dosing. This is the NeoFACS, and most of these drugs have these lines where there is no data available for pediatric patients with renal impairment, and they follow dose adjustments based on adults with renal impairment. There's no way you're going to have a neonate with less than 1 month with a a GFR of 80. So there is a serious risk of overdosing and underdosing when using these references, but this is the best that we have now. So again, what strategies do we use to adequately dose our infants? So we again should be using frequent assessment of creatinine and eye on the fluid vigilance, because we know that most of these drugs are distributed in the water or in the volume of distribution changes with fluid overload. Use therapeutic drug monitoring where and when applicable, and look out for drug toxicities always when you're using these formulas to calculate renal clearance, and especially in a child with low GFR. So in summary, we should understand that nephrogenesis and postnatal maturation have an impact on GFR. Variations with age, gestational age, and disease states are present. We have very limited tools, and most of these tools have shortcomings. The strategies to improve accuracy include frequent monitoring, using multiple markers, attention to drug toxicities, and using surrogate markers. Thank you. I'll leave you with this slide. I have an amazing team behind me, and this is a team that I get to work with every single day. We are really fortunate. Thank you. Thank you for your patience here.
Wonderful, Sukanya. You have set the ball rolling with your succinct talk on the ABC of renal functions in neonates. We now move on to the second talk of this session. May I invite Dr. Ambalavanan. He's a professor of pediatrics. Yes. Good evening and welcome. He's a professor of pediatrics and co-director of the Division of Neonatology at the University of Alabama, Birmingham. He's also an alumnus of the prestigious institutions that you just heard, JIPMER and PGI Chandigarh. He has been an investigator for many NIH-funded trials and is a member of the Neonatal Kidney Collaborative, the NKC, that undertakes landmark research in neonatal AKI. Today, I observe that he is placed in a very tricky position between two nephrologists, and I hope that this is not his routine real-life experience. Over to you, Dr. Ambalavanan.
Thank you. Let me share my screen. Okay, here we go. Okay, so it's actually morning for me and evening for you, so good evening to you all. So the objectives of this talk are to discuss the definition of acute kidney injury, discuss why defining neonatal acute kidney injury is difficult, and discuss the role of biomarkers in defining acute kidney injury. I'm not going to be talking about prevention and management of acute kidney injury because that's the next talk, and Dr. Sukanya has very nicely covered GFR in the previous talk. So what is neonatal AKI? AKI is classically defined as a sudden decline in kidney function, obviously, which will result in derangements of fluid balance, electrolytes, and waste products. So as we just discussed, the definitions of acute kidney injury in the adult, they're not applicable to pediatrics. So children are not just small adults. The same thing can be said for neonates. So definitions of pediatric AKI are not applicable to neonatal AKI. Newborns are not just small children. One of the problems is that the acute kidney injury definitions keep changing. So every few years, people come out with new definitions. There is the rifle classification, the risk, injury, failure, loss, CSRD definition from 2004, the AKI definition in 2007, the pediatric rifle in 2007. So there have been multiple ones that you can see in this table, which we published a few years ago, which basically classify acute kidney injury based on the magnitude of increase in serum creatinine, either in absolute terms or as a percentage term, or in terms of urine output, less than 0.5 ml per kilo per hour or less than 0.3 and so forth. So obviously, the higher the creatinine increase, the worse the magnitude of acute kidney injury. Then the KDIGO came in 2012, which also had a very similar type of definition with a magnitude of increase in serum creatinine and urine output criteria, with a higher increase in creatinine or less urine output being a higher stage of AKI. However, most of those were developed based on expert consensus. And then in 2016, the National Institute of Health in the US, especially its NIDDK, the Institute of Kidney Diseases, had a panel discussion where we came up with a neonatal AKI definition, trying to merge different definitions together. And we had both the serum creatinine criteria and the urine output criteria, which is on the next page. So you can see on the right of the screen, the neonatal modification, which is basically a stage 1, 2, and 3, where we had both an absolute increase of more than 0.3 or equal to 0.3, or 50 to 90% increase from baseline, or if it is more than 2.5 absolute or needing renal replacement therapy, or more than a 3-fold increase from baseline, that would be a stage 3. And the urine output definition, we thought a lower urine output might be better. So again, less than or equal to 1, or less than or equal to 0.5 or 0.3. So that was the definition we came up with in 2016, which was published in 2017. And after that, there have been newer definitions, which I will discuss briefly. So why is it challenging to diagnose AKI in newborn infants? Some of the challenges are, there are changes in renal development with gestation. There are changes in physiology at birth, both in fluid and electrolyte changes. Normally, the fetus, once they are born, they tend to lose some of their extracellular fluid. So there's a reduction of ECF. And also, we admit these babies to our NICU and we give them lots of fluid, so they end up with fluid overload, either iatrogenic or due to renal dysfunction. And all these fluid and electrolyte changes also change your assessment of creatinine. There are also normal postnatal changes in serum creatinine and renal function. And the practical point is, it is hard to get much blood from our tiny babies. So the small volumes of blood and infrequent serum creatinine measurement means we are always at a disadvantage compared to older kids or larger adults with lots of blood that they can get sampled frequently. There's also the practical difficulty of measuring urine output in small preterm infants. And finally, there's a lack of rapid, cheap, and easy acute kidney injury biomarker measurements such as NGAL or cystatin C. Some of the things I need to mention to you are that the preterm kidney is especially very prone to acute kidney injury. So the kidney develops like an onion. So you have multiple layers of glomeruli, which are developed from the center, and then you keep adding layers of glomeruli as you move out towards the periphery. So this is the fetal kidney at 19 weeks of gestation, showing 6 glomerular generation. Each glomerulus layer is shown with a green star. So there are 6 generations at that time. And then, as you can see, the gestational age on the y-axis and the glomerular generations on the x-axis. So you can see that as gestation increases, the number of glomerular generations also increase. So by the time an infant is term, you should have about 14 glomerular generations. What happens if a baby is born preterm, say at 24 weeks of gestation? So you would see from this graph that they have about 7 or 8 glomerular generations. So I think this was briefly mentioned in the previous talk. So you can see that a term infant has slightly less than about 10 glomerular generations. I mean, the previous graph showed 14, but there are differences in how exactly they're assessed. But assuming that a term infant has about 10, a preterm infant by about 40 days of age has about 8 glomerular generations if they don't have renal failure. Whereas if they do have renal failure, they're restricted to about 6.5, which is close to what they have soon after birth. So the presence of acute kidney injury decreases glomerulogenesis. And even if there is no renal insult, if there is no AKI, still the presence of prematurity acts to decrease glomerulogenesis. Remember that normally the glomeruli develop in utero, And once you expose these kids to an ex utero environment, there's a lot more oxygen exposure, there are a lot of nephrotoxins. So it's not good for the developing kidneys to be ex utero. So what should the normal kidneys do? As you all know, maintain salt and water homeostasis, electrolyte homeostasis, metabolize drugs and clear waste products. So that's what normal kidneys should do. But what's normal in a preterm? So by definition, a preterm infant is not normal because they are born too early. So does it mean that all preterms have an abnormal physiology? Generally, what we would think is appropriate is that we think of normal in terms of what's normal for that gestational age for the population. And also what we do as clinicians also helps to define normality for that population. So for example, they may not be able to feed by mouth, but we give them fluids, and we also end up giving them multiple medications. So this is just a chart of GFR by inulin clearance, both in term infants and preterm infants. Again, these are slightly larger preterm infants, but still you can see that the GFR soon after birth is quite low. And even by 4 months of age, it's still quite low compared to a term infant who reaches that level of GFR probably by a month or 3 months of age. So a preterm infant, as I mentioned earlier, has fewer glomeruli. Probably if they are more preterm, they have even fewer glomeruli, and they have a restriction of their maximal GFR. And I think this is something that we discussed in the previous talk about the limitations of serum creatinine, that the changes in serum creatinine are quite late. You need to lose about 25 to 50% of your kidney function. And at low GFR, you end up overestimating GFR because of tubular secretion. And changes in serum creatinine can occur without kidney damage. And different methods produce different values, such as the Jaffe method, which is not very accurate. Many centers have not yet moved to more precise methods. And obviously, if you have an infant on dialysis, then your kidney function is a bit harder to assess. Also, practically, blood loss from daily measurements can be a big deal in these babies. If you have a 500 gram, 25-weeker, the total blood volume may be only 40 ml. So you don't want to take out too much blood from these infants on a daily basis. And if you don't collect blood samples, you're not going to find acute kidney injury because you're not testing for renal function. And we're going to talk a little bit about the normal changes in serum creatinine over the first week of life. So this was by Galini about more than 20 years ago, and you can see that the one with dark squares, that's gestational age less than 27 weeks. So the infants who are more preterm, they have a higher peak in serum creatinine, which is probably closer to the middle or the end of the first week of life. Whereas the more mature preterm infants, let's say 28 to 32 weeks, they have an earlier peak of serum creatinine around day 1 or 2 of life. So you have an earlier peak with more maturity, but then after that, it gradually comes down. So it's considered that this initial peak is because you're losing a lot of extracellular fluid and you have a concentration of the creatinine. And obviously, you know that the initial creatinine reflects the maternal creatinine. So how exactly would you go about defining AKI? Are you just going to use a threshold above which you call it AKI? Or are you going to say, well, instead of coming down, if it starts going up again, maybe that's AKI? Or maybe you're going to say it peaked, but then it's not coming down from the peak. Would that be AKI? So, I mean, all three could be considered as acute kidney injury. And this is a study from India where they did a similar look at larger preterm infants, 33 to 37 weeks, and closer to term, 38 to 42 weeks, showing that they really don't have much of a peak, but there's a gradual decline from soon after birth. And this is the creatinine clearance in preterm infants. So the white bars are less than 27 weeks, and the ones that the striations are more mature preterm infants. So you can see that it depends not just upon the postnatal age, but it also depends upon the gestational age. The more immature an infant, the lower the creatinine clearance. Yes, it does increase over time, regardless of maturity, but the amount of increase is different. And while by say 6 to 8 weeks, you have a much improved GFR, the more immature infant still has a lower GFR. So we developed the AWAKEN cohort, which is again a worldwide study with multiple centers across the world. And we looked at, for this study, we looked at 990 infants who were admitted to the NICU for within the first 14 days and who received IV fluids for at least 2 days. So this is not all normal infants. So these are somewhat sick infants who did not have any congenital anomalies of the kidney or urinary tract, and who did not obviously die or have other chromosomal anomalies. So we looked at 2 serum creatinines in the first 2 days of life and between days 3 and 7. So the lowest creatinine in the first 2 days was considered a baseline, and that in the highest creatinine in the later time point was the peak. So we basically compared the peak versus the baseline to get some idea of what's clinically important. So we calculated the change between the baseline and peak, and we evaluated them both as a percentage and as absolute numbers. And you can see whether you look at it as an absolute change or as a percentage change. The higher the change, that is, the more the increase in serum creatinine, the higher the mortality, that is the dashed line. Most infants, fortunately, don't have a big change in creatinine at this time point. And what we did was we looked at the performance of these KDIGO thresholds for absolute serum creatinine rise, percentage rise, and the combination predict mortality. And then we also used what's called an AUC-driven optimal thresholds. That is, we combine the sensitivity and the specificity for an area under the curve of a receiver operating curve. That's the AUC of the ROC curve. So that's a way to identify what's your optimal threshold. And then we did other specificity-driven thresholds and other modeling, which I'm not going to go into detail because of lack of time. But if you just look at the absolute serum creatinine threshold, that was the most sensitive, that is a sensitivity of 92% for those infants who are less than equal to 29 weeks. However, the specificity wasn't that great. But if you look at the larger preterm infants, 29 to 36 weeks, the 0.3 milligram per deciliter cutoff had poor sensitivity, but it had excellent specificity. So depending upon the maturity of the infant, your thresholds will vary. So we actually found that the absolute threshold was somewhat better than looking at the percentage rise. So we think that an absolute serum creatinine rise is probably more accurate to use. And then if you're looking at the AUC-driven threshold, we found that the best or optimal thresholds for maximizing sensitivity and specificity was an absolute creatinine increase of 0.3, 0.1, and 0.1. So this is a very small increase. So even a change of 0.1 is, I would say, very important for this population. And remember, this is for predicting mortality. So just to recap, best for the AUC, less than 29 weeks is 0.3. For larger preterm infants, it's 0.1. And for specificity, you want a higher threshold, that's 0.6 or 0.3 or 0.3. Some people use urine output-based definitions. Obviously, the kidney has to make urine. And if you have a less urine output, that suggests acute kidney injury. But that depends a lot on intake, which is to some extent determined by the physician. And it's also difficult to measure accurately. It might be mixed with stool. It may be evaporating from the diapers or nappies. So it's a bit hard to measure. And some infants, especially those who have had a intracranial bleed, may have inappropriate ileate secretion. Some clinicians use diuretics. And non-oliguric AKI is also quite common in preterm infants. So there are some challenges with urine output-based definitions. So moving on quickly to the biomarkers, So what we want to do is identify the stages of risk or early injury. We don't want to wait until the infant has developed the later stages when it's hard to reverse. So why do we need biomarkers? So we want to have an earlier diagnosis at the stage of risk or injury so we can prevent or treat it from getting worse. You might be able to differentiate between different causes. You can probably identify the location of primary injury. Is it the proximal tubule? Is it the interstitium, vasculature? You might be able to identify the prognosis, the stratification, identify the duration of kidney failure, and obviously use a surrogate endpoints. So what happens if your biomarkers are increased, but your serum creatinine isn't increased yet? So we don't know that for sure in newborn infants, but we do know that at least in other populations, if you have no AKI, your risk is pretty low. But even subclinical AKI, that is biomarker positive, creatinine negative. So that has almost the same implication as an increase in serum creatinine. So whether you have subclinical AKI, that is only biomarker positive, creatinine negative, or creatinine and biomarker positive, they have almost the same outlook. So we all know about different biomarkers predicting acute kidney injury. One of the things we look at is NGAL, which is a bit easier to do. And again, the magnitude of increase is quite correlated with the rise in creatinine later on. And in very low birth weight infants, we have looked at multiple biomarkers. It turns out that NGAL, cystatin C are quite useful. There are other ones such as KIM1, interleukin 18, osteopontin, and so forth, which may also be attempted. But one important thing to remember about these biomarkers is that they are higher in more preterm infants, and they are also higher closer to birth. But then after a while, they start declining. So again, it depends upon the gestational age, it depends upon the postnatal age, and it also depends on what exactly you're measuring. So what do we do with these results? So identification of the temporal course of the biomarkers. So if you take a value today, take a value tomorrow, and then the day after that, that might help you identify the timing of the injury and the nature of the injury. And there are some biomarkers that have increased in the so-called pre-renal acute injury or the oliguria induced, other oliguria because of dehydration. And those usually recover once you hydrate these infants well. And the ones that usually go up with pre-renal injury are the KIM1, cystatin C, and interleukin 18. On the other hand, NGAL usually does not increase with pre-renal. And this may also help guide therapy. So in conclusion, acute kidney injury and most neonatal disorders are complex and multifactorial, especially in a small sick infant in the NICU, because there are a lot of things going on, and it's a very complex clinical situation. So recognition of acute kidney injury is difficult, especially if the infant has multiple pathologies. The operational definitions of acute kidney injury, which we use based on serum creatinine or urine output, they don't capture the phenotypic heterogeneity. This is not all types of AKI are the same. And there's also possible genetic heterogeneity. For example, you have different babies who all have the same risk factors, but why do some infants develop AKI and others don't? It's possible there are genetic risk factors. And what the future holds is that unbiased evaluation of biomarkers, such as NGAL and cystatin C, may help earlier diagnosis, prognosis following response to therapy, and may occasionally yield insight into the underlying disease mechanism. So we really need a better understanding of the specific pathophysiology in our sick infants, and identifying disease progression, which may suggest potential personalized intervention. So we don't want to use the same cookbook approach for all infants. We need to identify what's wrong with a specific infant at a specific point in time and target our therapy. Thank you.
Thank you so much, Dr. Ambalawanan. We regularly see your name alongside Dr. David Ashkenazy's name in several publications, and today I'm sure everybody would agree with me that we are fortunate to hear it all straight from the horse's mouth. Thank you so much.
Thank you.
We now move on to the third talk, much awaited, because we are here to welcome a colossal figure in pediatric nephrology, Dr. Stefano Picca. Buongiorno, Dr. Picca. Dr. Picca is a pediatric nephrology consultant at Bambino Gesù Children's Hospital, Rome, Italy. He was the former head of the dialysis unit there. He's also the ISN Education Ambassador. He has served as the regional advisor for Africa. Also is one of the lead faculty in the Saving Young Lives initiative, delivering teaching programs for low middle income countries. He's the co-founder of European Study Group on CKD in Children. He is instrumental for planning of the continuous dialysis therapies in the huge institution of Bambino Gesù Hospital. I've had the pleasure of meeting him a few years back at his institution, as we are sister transplant centers under the ISN. We look forward to your talk on prevention and management of neonatal AKI. Over to you, Dr. Picca.
Thanks very much, Arpana. And can you see it? Okay, good. Okay, thanks very much for inviting me. I will try to concentrate in 20 minutes, a huge issue like the prevention and treatment of acute kidney injury in NICU. Let me introduce myself first. As Arpana was saying, I come from this hospital here. It's a large pediatric hospital in Rome, some 500 beds for inpatients, and it has four intensive care units. One of these is the neonatal care unit, and I was responsible, as Arpana was saying, of the dialysis cooperation plan with our friends and colleagues and intensivists. We had a wonderful relationships for years, and we accumulated quite an amount of experience about treating, about making dialysis to these children. And well, actually, the hospital is located 10 minutes walking from St. Peter's Square, is this building up here. In order to do to make things as clear as possible, I will divide my presentation in talking about risk factors, about pharmacological prevention, and then the treatment. And I will try to meet all the possibilities of our listeners, imagining the treatment in three different situations: when you have no dialysis, when you have only peritoneal dialysis, and when you have also extracorporeal dialysis. So let's start with risk factors. We all know that there is a number of primary diseases or iatrogenic situation like sepsis, asphyxia, cardiosurgery, or ECMO that do predispose neonatal population to acute kidney injury. So I want actually to put the accent on something particular that concerned the NICU period, and that is nephrotoxic agent. When we deal with critically ill neonates, we usually use a number of nephrotoxic medications. Now, I found that this study coming from Dr. Ambal group, that is David Eskenazi in Birmingham, Alabama, one of the most interesting piece of study about that. What they did, they made a protocol in a single center, that is Birmingham, and they call it the Baby Ninja, and they just applied a previous protocol by Stuart Goldstein that was called the Ninja study about nephrotoxicity, but they applied that to neonates. And what they did was just implementing the surveillance through a very nice and important collaboration with the hospital pharmacy. And briefly, they divided the study period into 3 periods they called eras. That is before the setup of the study. That is the washout is actually the setup of the study. And you see the blue bars, that is the exposure to nephrotoxic medication, and the red bars are the number of acute kidney injuries. So starting from this baseline, you can see like in the first era, there was an increased number of detection of exposures, an increased number of detection of acute kidney injury, but is in the maintenance sustainability era, that is the 1 year and now the following 1.5 year, that you see that the number of detection of exposures was stable, while the number of acute kidney injury was significantly decreasing. So that's, to me, is very interesting, because they used no magic bullet, they used no special medication, they just increased surveillance. And just increasing surveillance, and they had this incredible result. So it's a sort of an invitation to take a look to this kind of approach. We don't have actually any dedicated guideline for nephrotoxicity in neonates, and we can refer to the adult one. You can find in the KDIGO guidelines. Pharmacological prevention is actually the quickest part of my talk, since I know, to the best of my knowledge, that there is no specific drug that has sorted out a scientifically demonstrated action on the prevention, except for the non-selective. Come si dirà giusto a fare?
Quale?
Questo qui?
Non si dirà giù.
Non si dirà giù, okay. I'm sorry. Except for the non-selective adenosine receptor antagonist, that is theophylline and aminophylline. You know that the blockade of this system promotes arterial dilatation and natriuresis. And in the asphyxiated neonates, the risk was reduced by 60% on average by these authors. And a consequence of this result was the KDIGO guidelines suggest a single dose of theophylline in neonates with severe perinatal asphyxia to prevent acute kidney injury. There is no study in non-asphyxiated neonates. I am aware that Sukanya, our host, is very much involved in this issue, and she has brewing ideas about that. And I would not be surprised if very interesting results will come out in a short while. Let's go on and see what happens about treatment when you have no dialysis. Maybe everybody or every one of us, pediatric nephrology, perhaps when we were young, we pose ourselves this question: why what a patient, what a child, or what a neonate with acute kidney injury die of? Actually, the causes of death in NICU during acute kidney injury are basically 3. That is fluid overload, and that is drowning in his own water, in our own water, or I better say, probably drowning in the water that somebody added to our own water. Potassium and acidosis. These are the 3 most frequent causes of death during acute kidney injury. This is the AWAKEN study that Dr. Ambalavana has already mentioned from his group and David Eskenazi group. And the AWAKEN study has provided a tremendous amount of knowledge about the acute kidney injury neonates. This is one of these pieces of knowledge that I find that is very well known, over more than in more than 600 neonates, the final result is that more or less 1 out of 2 children is may present in NICU acute kidney injury. And the other one was the confirmation that fluid overload in neonates, as in older children, turned out to be an independent predictor of death and was associated with mechanical ventilation. So what to do in practice when you have no dialysis? So you have basically 2 situations. The first one, if you have a urine output, and the second one, if you have not a urine output. What if urine output present? As per WHO recommendation, you have your hydration test, 20 milliliters per kilogram saline. And if you have hypotension or sepsis, you have to start pressors, always remembering then that the old renal dopamine dosage of the 3 to 5 micrograms per kilogram per minute does not work. It simply was a fake news that lasted for years. And if you have a persistent anuria, then you have to restrict something, and you have to minimize fluid intake by these possible means. You have to concentrate parenteral nutrition, you have and drug dilution, and in neonates, perhaps enhance perspiration by increasing the external temperature. If you have the heater of a cradle, you can do that with caution, but it may help in make the newborn baby lose water. Actually, once again, when we talk about fluids, nobody says from Stuart Goldstein on that we do not have to give fluids. Fluids are necessary, but the point is that the fluids are undoubtedly necessary during the resuscitation phase, and that's what usually happens. Then there's a maintenance or homeostasis in which we don't have to increase without any reason the fluid volume given, and that is frequent. But the removal recovery of fluid, it's often lacking. And this is what we should do, and always keep in mind when we treat neonates by fluids. What about acidosis? We all know that the formula of sodium bicarbonate, but there's a caveat in neonates. Sodium bicarbonate has been associated with a number of serious side effects like intraventricular hemorrhage, fluctuations in cerebral flow, tissue oxygenation, worsening of intracellular acidosis, and cardiac problems. So the solution of this is always a balance between the necessity and the possibility of other chances that you may take. Usually what they say is to cure the underlying disease in order to avoid acidosis. But if you think, comes to my mind, some cardiosurgery neonates coming out from the operating room, it's very hard to cure the underlying disease. So it's a compromise. What about potassium? Prevention of potassium, there's the verification that you are not giving potassium, like a ringer, for instance, is fundamental. Correct acidosis to not to increase kalemia, and to take into account the potassium in blood products. One should always remember that a standard packed red cell blood unit, that is 200 to 250 milliliters, may contain up to 50 milliequivalent potassium. What about treatment? You have basically 3 mechanisms: antagonize potassium action on cell membrane, that is calcium infusion, you may enhance potassium entry into intracellular space or with the insulin, or you can remove potassium by cation exchange raising KX-late or resonium or diuretic. Concerning exchange resin, there's to say that the use of these drugs has been associated with intestinal problems in neonates. And let's move to dialysis. If one should consider the use of the treatment from an economic point of view, and let's imagine we have a gross domestic product, then things should arrange more or less this way, because theoretically meds are the less expensive. PD is not very much expensive, while extracorporeal dialysis is very much expensive. Nonetheless, there is something to say. In countries when a peritoneal dialysis first policy has been instituted, the proportions of chronic patients on PD are higher. In India, this is a very recent result by Siddharth Sethi. 84% of pediatric patients are treated by peritoneal dialysis, like in other parts of the world, like Hong Kong, Mexico, Thailand. On the contrary, if you go in different realities, like for instance, sub-Saharan Africa, among patients able to access dialysis, up to 46% of children are treated with acute kidney injury, are treated by hemodialysis. It sounds like a nonsense. Actually, in my experience, what I've seen that hemodialysis is more used in French-speaking African countries, probably because of tradition, while PD is in general more used in English-speaking African countries. There's also to consider that in low to low medium income countries, in contrast to higher income countries, PD tends to be sometimes more expensive than extracorporeal. That's because of the import of PD fluids, supplies, legal and illegal taxes and levies. If my African colleagues connected can understand what I'm talking about. So I think that the KDIGO approach, this sentence by the KDIGO 2012 is very much appropriate. Understanding local needs and developing a local sustainable and equitable solution to improve access to kidney care is the right way to follow. What about PD? PD can be very easily instituted, even at bedside, by pediatricians, nephrologists, intensivists. Sedation and local anesthesia can be enough to puncture an abdomen, and by Soldinger technique, put a catheter, even very small catheter in neonates, down to 8 French or 10 French vascular catheter, and be used for peritoneal dialysis. And this is and this may save lives. This is one of the issue, or I would say the mission of the Saving Young Lives program in the International Society of Nephrology. And as was said before, I'm part of the Saving Young Lives program. Some novelty about peritoneal dialysis. This is my friend Peter North from Cape Town, South Africa, who re-edited a previous idea of putting 2 catheters in children and having a continuous flow peritoneal dialysis, so without dead times inside. And with this solution, he made 2 studies actually, showing that you can reach the same clearances and water removal efficiency of extracorporeal dialysis. This is one of our neonates, and with you can see here the two catheters. what about extracorporeal? There are since some 2 decades tremendous improvement in materials. This is the HF20 that in Europe we have had since some 20 years, but it's only in the United States, it's only since few months available. And this is a very small filter, it's called the HF20. And we have treated with a pre-priming the circuit, we have treated neonates and even prematures since the year 2000, I would say, more or less. There are presently there are 3 dedicated machines for neonates. One is the Aquedex, and it's used in David Eskenazi and Dr. Amal unit in Birmingham, Alabama. The other one is Dr. Coulter Nidus that is used in the United Kingdom. But we have this. This was made by Claudio Ronco. It's a very fine. Maybe you've heard of him or you know him very well. It's from Vicenza, Italy, and he made up this Carpe Diem unit, and it says very low priming volume down to 25 or to 45 milliliters of priming. This is our series. This is my unit, and this is actually, it's not my unit, it's the intensive care unit where I set up these techniques, and this is our experience. 15 units treated. Survival was very low, but we have to say that for 13 out of 15 were from cardiosurgery, and they were very, very sick. And finally, that's what I consider the most important message I can give to you. You always to remember that the time windows, according to the classical schema of the acute kidney injury clinical course, tells us that the problem takes place in a very short time, actually the first 24 hours. So what can we do about that? We do that, and we have this weapons to use. We have fluids, we have drugs, we may have drugs, we have dialysis, and we have to recognize the acute kidney injury in time to make our treatment efficient. Now, let's take 2 opposite situations. That's always something we did. That was something crazy we did. There was an 8-kilogram infant with a measles sepsis, and he was on 3 simultaneous extracorporeal circulation. He had ECMO because of lung failure. He had dialysis because of kidney failure, and he had plasmapheresis because of liver failure and hyperbilirubemia. Logically, this died, and I always ask myself if this was a futile exercise compared with what we can do. And that's another. That's the other side of the medal, we say in Italian. That's a very important paper published years ago by Mirella Habokan, which is an intensivist from Necker Hospital in Paris. And what she did is she took some 150 neonates from cardiosurgery, and she randomized the treatment with PD. I'm talking about the less efficient dialysis modality in early PD, that is done in the first day after the surgery, and delay PD, that is after 2 or 3 or more days. And what she found is that at 30 and 90 days, the survival was significantly different and significantly better in early PD. So when you are faced to these very complicated patients, I think that a very good exercise is always ask yourself, is he so sick because he has a horrible disease or because someone, maybe me, waited too long? And the final conclusion is that in neonatal acute kidney injury, the timing of whichever intervention, prevention, medical treatment, dialysis is very likely the priority. Finally, that's the Saving Young Life course. She's Mignon McCullough. Maybe some of you know her. She taught me I think everything I know, all the things I know about Africa. Yeah, that's me. And this is me in Haiti, and this is me in Senegal, and this is my friend Dr. Yunusa Keita, treating the first acute kidney injury neonate with PD in Senegal. There was 2 years ago now. These are my nurses. This is my email for. I'm available for any sort of question, and I thank you for your attention.
Thank you, Dr. Pika, for a very comprehensive talk and for giving us practical insights into managing neonatal AKI.
Thank you.
We now just jump into the chat box and the question answer box. And in the interest of time, I think I'll just choose 2 or 3 questions. The first question is to Dr. Ambalvanan. A delegate would like to know the role of urinary NGAL in the early diagnosis of AKI in newborns.
Yeah, so I think one of the issues with NGAL as opposed to, say, creatinine is that right now it's there are not too many methods for measuring NGAL. People are coming out with point of care testing and rapid methods. But right now, I think it's still a little bit more of a research tool, though I think it's rapidly entering clinical practice. I think cystatin C is also somewhat similar in that more people are using it now, but it's not, at least blood cystatin C is also becoming more used, but still it's, I think both NGAL, cystatin C are not yet prime time in terms of being routinely used for many infants. And if you're going to do it, I would look at published values for what's a normative range for that birth weight and postnatal age, because obviously, you know, the more preterm an infant, you're going to have a higher value, and also earlier to birth or closer to birth, you're going to have a higher value. So you want to look at what the age is in gestational age and postnatal age and modify based on that.
Thank you very much. The next question is to Dr. Pika. I had the same question in mind for you, and there's another delegate who has asked the same question. So this is on the role of a bedside tool, like a near infrared spectroscopy for renal oxygenation. What is your thought on this tool?
Dr. Pika, could you unmute yourself?
I'm sorry about that. Okay. Are you talking about NIRS, right?
Yes.
Okay. We had an initial experience with that frankly speaking, aborted because there was problems in setting up the study. But the impression is that neonates are the ideal population because the wave is cannot be applied to a large size patient. So neonates are good. And what we do is both cerebral blood flow and kidney blood flow. And there was some difference in acute kidney injury, but we never finished the study. So I think it's a very good idea. There is something published about neonates, but it deserves more attention, in my opinion.
Thank you. And the last question would be to Dr. Sukanya. There are a couple of delegates who'd like to know the role of furosemide infusion in newborn AKI, especially when there is oliguria.
Okay. So furosemide as such does not alter the codes of AKI. Furosemide should probably be used as a tool for augmenting urine output. Furosemide stress test has been time and again discussed as a tool to, identify the type of AKI. But other than that, furosemide as a therapeutic thing should be only to augment Maybe my other speakers can add on to their experience with this.
Dr. Anbalwanan, would you like to add?
No, I think that's probably a good explanation. Again, we try not to use too much furosemide because, again, it ends up causing more trouble than benefit, especially in the small baby with electrolyte imbalance. And also, we find that with furosemide, the risk of nephrocalcinosis and is also much higher. So we generally try to avoid diuretics as much as possible.
Yes, nice to see that the neonatologists and the nephrologists are on the same page. I think we have to close this session. I thank Dr. Pika, Dr. Ambalavanan, and Dr. Sukanya for a very informative and enjoyable session. Thank you so much. We move on to the next session. Over to you, Dr. Pooja.
Just a quick word, there are many questions which are unanswered. So if any of the panelists want to sort of type an answer to them, please go ahead and type the answer. We'll try and cover as much questions as possible if time permits. Now Pooja will take over. Thank you.
Thank you. After the end of this very informative session, we now move on to the next session, which will be on clinical case-based discussion. This session is being co-chaired by Dr. Rukhsana Shroff and Dr. Aditi Sinha. Dr. Rukhsana Shroff is currently the professor, Department of Pediatric Nephrology at Great Ormond Street Hospital and also University College London. She holds a prestigious senior fellowship from the National Institute of Health Research. She's also the co-editor of the 8th edition of Pediatric Nephrology. She has been a member of the executive committee in kidney disease and improving global outcome, and also a member of the International Guidelines Committee for KDIGO, NICE and ESPN. She is also she is an educational ambassador for the ISN and currently manages 3 sister renal centers across India and Vietnam. Dr. Aditi Sinha. Dr. Aditi Sinha, currently she is the Associate Professor, Division of Nephrology, Department of Pediatrics at All India Institute of Medical Science. She has received various awards, among which is Dr. H.P. Dingley Memorial Award for her ICMR research in pediatrics. She's also the Commonwealth Medical Fellow at Manchester, UK. She's been the junior representative of India for IPNA Council. Over to you, ma'am.
Thank you very much for introducing us, Pooja. I think in the interest of time, Aditi and I will just launch straight into the talks. So we've got 4 very interesting case-based discussions today on a range of topics. And what we'll try and do is be a little bit strict with timekeeping, but do all these 4 sessions so individually, of course, with the presentation followed by questions and answers, and move through all 4 together. Is that okay, Aditi?
Yeah, absolutely okay. So without much ado, should we just jump ahead and go on into the first case presentation? Our speaker for this case presentation is Dr. Arun Krishnan. Dr. Krishnan has done MD in pediatrics and DM in neonatology and is currently working at Mehta Multispecialty Hospitals, Chennai. He has publications in the Journal of Pediatrics on his work on paracetamol versus ibuprofen in management of patent ectostatitis in preterm infants. And he is interested in pursuing neonatal functional echocardiography. So Dr. Krishnan would be speaking to us about cases which are associated with hyponatremia. Over to you, Dr. Krishnan.
Good evening, madam. I'm Dr. Arun from Mehta Hospital. I'm going to discuss about 3 neonates with hyponatremia. So this is the first case of 27 weeks neonate with 760 grams in weight and required 3 doses of surfactant and was on mechanical ventilation for 7 days and followed by CPAP. On day 12, the baby was still on CPAP with FaO2 of 35%. And our chest X-ray was showing congested lung fields, probably because of prematurity. The echo was done to rule out PDA, and the IBC size and collapsibility index were normal. So that was indicating normal fluid status. So in an attempt to take the baby out of the CPAP and following a congested lung field, we started the baby on hydrochlorothiazide at 2 milligrams per kg per day. So that was a congested lung fields on day 12. And day 16, the baby started to throwing up some seizures. So we're all worried. We thought of sepsis. As usual, we do that. And septic screening was done. Lumbar puncture was done, which all negative. And blood culture was negative. So but the baby's electrolytes were abnormal. Having a hyponatremia, severe hyponatremia. And since it was symptomatic, we started the baby on 3 ml per kg of 3% saline bolus, followed by infusion of 3% saline at the rate of 1 ml per kg per hour. At around 6 hours, the second value was done, which was showing not much of a change. Probably the first dose of hydrochlorothiazide in the morning was given. So we were expecting the duct was there on the system, so it was not helping us much. Then we continued the infusion at 1 ml per kg per hour. And 18 hours, unfortunately, the base sodium jumped from 97 to 136, and following which the 3% saline infusion was stopped. And 24 hours and 48 hours, rest of the values are stable. During the acute phase, fractional excretion of sodium was also very high, and calcium creatinine ratio was very low, indicating hydrochlorothiazide toxicity. The neonate started to have lesser activity in upper limbs and compared to lower limbs. We are worried about because of the osmotic demyelination the baby might have undergone because of the rapid fluctuations of the sodium. But fortunately, the baby's activity returned to normal in all 4 limbs after 48 hours. And baby was discharged after 10 weeks of hospitalization and is doing well in the follow-up. So the case number 2, which is a 25-weeker, 780 grams with respiratory distress syndrome requiring 2 doses of surfactant, was on mechanical ventilation for 8 days, followed by CPAP with FaO2 40%. And X-ray again was suggestive of bronchopulmonary dysplasia, evolving bronchopulmonary dysplasia. So we started the baby on hydrochlorothiazide in order to take the baby from the ventilation at 2 milligram per kg per day. At day 21, that's in around 4 to 5 days after starting hydrochlorothiazide, baby was having a sodium of 119. Baby was asymptomatic, so started on a sodium infusion at 1 ml per kg per hour. After 6 hours, the baby's sodium was slightly improved. We changed to maintenance fluid, targeting a change of 6 to 8 milliequivalents per day. So this is a formula we use, like total body sodium plus sodium to be supplemented, divided by the total body water plus the new volume we are going to add, and that should be reaching to the desired sodium. And after using the maintenance target of 6 to 8 milliequivalents per liter per day, we achieved somewhere around 128, and then the sodium adjusted or 4 milliequivalents per kg per day. So from there on, it actually reached a steady state of normality. Baby also had a hypercalcemia of 1.645. Ionized calcium 1.645, probably because of the thiazide effects, and for which we started the baby on hydration, adequate hydration, not use furosemide because of the existing hyponatremia. And to wash the calcium that can be seen from the calcium creatinine ratio, which was 0.4, became of or rest of the course of the baby was uneventful. The mechanism of action of thiazide diuretics is like it acts on the distal convoluted tubule, blocking the sodium chloride co-transporter. So it prevents absorption of sodium and chloride. It increases the secretion of water. It also promotes calcium absorption, and thereby in the people and also promotes calcium absorption. The hyponatremia less than 120 with seizures. We generally start on bolus like 3 to 5 ml per kg of bolus. If it is asymptomatic, we try to increase the sodium of 2 to 4 milliequivalents per liter in 4 hours by using infusion of 1 ml per kg per hour of 3% saline. We target a change of serum sodium about 6 to 8 milliequivalents per liter per day. We use fluid restriction whenever appropriate, and in case of we use this formula to just an approximate idea how much sodium to be supplemented. Just a workout like case of a 27 weeks with 1 kilo with a sodium of 119, the total body's sodium will be somewhere around 0.7 into 1 kilo for the weight, and 119 will be 83 milliequivalents. So the total body water, which is 70% of the weight, will be 0.7 liters, and the new volume which is to be supplemented will be designated as V. And the sodium to be supplemented in terms of 3% saline will be 513 V. So by just putting the values into the formula, we'll get around 15 ml of 3% saline given over a period of 24 hours will increase the serum sodium by 8 milliequivalents. There are a lot of pitfalls in this formula because we are not accounting for the ongoing urinary loss, and also we will be a lot of fluids for the maintenance. This will change the total body volume. So this were not accounted for. This may be a rough idea how much to be given to have a change in this. So the third case will be a term baby, 39 weeks, 3 kilos, uneven full perinatal period, and presented at day 8 of life with severe weight loss, hyponatremia, hypokalemia, and metabolic acidosis. Baby presented with a lot of ECG changes, bradycardia, and prolonged QRS interval. The baby also had a severe, had acute kidney injury because of anuria for last 12 hours. So electrolytes values were very abnormal, like 115 sodium, potassium of hyperkalemia of 8.2. Initial diagnosis we made was congenital adrenal hypertrophy. We started on fluid bolus, steroids, salbutamol nebulization, calcium gluconate to stabilize the cardiac effects of the hyperkalemia. We have also started the baby on potassium binders, and sodium bicarbonate infusion started. Ultrasound kidney was done, which was relatively normal, and the baby had a FeNA of 7.5, transtubular potassium gradient of 1.7. Since potassium was resistant to be treated, and the baby had a normal genital, we also took sample for plasma renin activity and aldosterone, which are all elevated. So hyperkalemia with elevated aldosterone, normal genitals, and normal 17-hydroxyprogesterone, the diagnosis of pseudohypoaldosterone was made. This baby was sent home with salt supplements. Like the point I want to make is, like in case of hyperkalemia with the hyponatremia and metabolic acidosis with normal genitalia, probably we should also look into the possibility of pseudohypoaldosteronism. So plasma renin activity and aldosterone samples to be taken after correction of the hydration status. So the baby was discharged with 5 grams of salt a day and salbutamol nebulization and K binders. The baby is awaiting genetic test. So in view of pseudohypoaldosteronism, there are 2 types, and there are further subdivisions based on the time of presentation, target organs, genetic mutation. They have different biochemical aspects. Some of like renal type 1 and early childhood hyperkalemia will be outgrown by the age, like one will outgrow by 2 years, another will be outgrown by 5 years. The rest of the things will require lifelong therapy. So summarizing, the hyponatremia and preterm is quite common because of renal immaturity, and the drugs we try to improve the baby's outcome, like hydrochlorothiazide for just increasing the lung congestion, or vasopressin, which is used in terms of pulmonary hypertension, acute kidney injury because of asphyxia, sepsis, neonatal Bartus, congenital adrenal hyperplasia, pseudohypoaldosteronism, and SADH because of asphyxia and internal hemorrhage can all lead to hyponatremia. And in case of acute hyponatremia, the correction should be catered slowly, like 6 to 8 milliequivalents per liter per day. And symptomatic should be treated aggressively. Again, the correction should be limited to 6 to 8 liters. 6 to 8 milliequivalents per liter. So I conclude the talk.
Thank you, Dr. Arun, for that very interesting presentation and very interesting 3 cases. So far, I do not see any questions on the chat box. The question and answers board is also empty. So I think all 3 cases were very interesting. And I think I would just summarize by saying that neonatal hyponatremia is a common electrolyte abnormality. Very often the symptoms would be very non-specific. You would have to look for it by ordering electrolytes. And as shown, very often the condition could be hospital acquired because of things we do to the newborns. We administer drugs, we do various things. You have to look out for problems associated with the kidneys. You have to look out for adrenal insufficiency, which often is transient. So it's not always a genetic defect. It could be a transient adrenal insufficiency causing and there could be pseudohypoaldosteronism that could be present. There could be evaluation as well as management would have to go hand in hand, because abnormal electrolyte values of sodium could result in serious trouble. So with that, I think there are no questions. Yeah, thank you so much, Dr. Arun.
Thank you, madam.
Over to you, Dr. Shroff.
Thanks, Aditi, and well done, Arun. That was great. So now let's move from hyponatremia with sodiums in the 90s to hypernatremia with sodiums in the 190s. And with this, I'd like to invite Dr. Nivedita Kamath, who's an assistant professor at St. John's Medical College, Bangalore, to do the talk. It was our pleasure to have Nivedita here at Great Ormond Street as an ISN visiting fellow, and she has achieved great things in her time at St. John's, with special areas of interest in CKD, chronic dialysis, and neonatal AKI. So over to you, Nive. Thank you.
Thank you so much, Dr. Rukhsana, for those kind words of introduction, and thanks to Dr. Sukanya for giving me this opportunity to present this case at this very unique neonatal nephrology symposium. So let me just begin. As we already said, dialysis in neonatal AKI with hypernatremia, to do or not to do. This is a 7-year-old baby girl who was born at term, normal delivery with a birth weight of 2 kg, so small for gestational age, born in a different hospital outside and referred to us. The maternal history, the mother was a primey with a normal antenatal period. She was exclusively breastfed. She was brought on day 7 of life with a 2-day history of irritability, poor feeding, reduced activity, rapid breathing, and reduced urine output, and no obvious history of any losses. On examination in the emergency room, she was drowsy, severely dehydrated with a weight loss about 20%. The skin turgor was the typical doughy skin, and the anterior fontanelle was sunken. She had expectedly tachypnea, tachycardia, and hypotension, and the peripheral circulation was compromised. Systemic examination, there was nothing significant noticed except that she was drowsy and had mild hypotonia, but no focal deficits were noted. The initial labs, as we just mentioned, were significantly deranged. The urea and creatinine were extremely high, with a sodium of 186, potassium of 9.9, with the ECG showing tall TVX, and severe metabolic acidosis with a base deficit of -21. Lactates were high, there was hemoconcentration and hypoglycemia. She was treated in the emergency room with fluid bolus up to 20 ml per kg. She received dextrose bolus, calcium gluconate, and sodium bicarbonate. And the dehydration correction was started with 15% deficit, along with the maintenance fluid of 150 ml per kg per day as dextrose normal saline. 2 hours later, her labs were still as bad as they were before, with sodiums being 192, potassiums were still abnormal, and ECG changes persisted. There was slight improvement in the metabolic acidosis. The sugars were normal. The blood pressures were better, but there was no urine output. At this point, diagnosis of hypernatremic dehydration with stage 3 AKI based on the modified Kiriko staging was made. And though most often in our mild hypernatremic dehydrations, the cause of AKI is pre-renal, here definitely with anuria that was there despite fluid boluses, severe ATN, perhaps even cortical necrosis, and a suspicion of renal artery or venous thrombosis was considered. Our center protocol for hypernatremic dehydration is to establish 2 good IV lines for maintenance and deficit correction, to repeat sodium after the bolus of normal saline has been given, to correct the deficit based on the weight loss percentage to a maximum of 15%. And the weight loss, the sodium correction is timed, the higher the sodium values, the longer the duration of correction. The sodium content of the IV fluid is kept at about 10 to 12 millicoulombs below the serum sodium, so as to avoid a rapid drop. ED is considered whenever there is anuria or signs of fluid overload. refractory metabolic issues, severe azotemia or uremia, serum sodium more than 200, especially when it is poorly responsive to conservative therapy. And again, we try and maintain the PD sodium at about 10 to 12 milligrams per liter below the serum sodium to prevent a rapid drop. In this baby, the indications were the AKI stage 3 with anuria, need to create space for fluids, and refractory hyperkalemia with persistent ECG changes and metabolic acidosis. The anticipated challenges were that this baby was still in shock and had severe hyponatremia, which could, if the rapid correction of which could be detrimental. We inserted a neonatal-sized rigid catheter with a dwell volume of 25 ml per kg, a dwell time about 30 minutes. The standard PD solution was used, but the sodium was increased by adding 3% sodium chloride to target a rate of sodium drop at around 0.5 milligrams per liter per hour. And the monitoring of electrolytes, sugars, and creatinine was done on a regular basis. A total duration of peritoneal dialysis was done for 48 hours, and we did not have any complications related to peritoneal dialysis. If we look at the trend, we see that this drop in sodium was about 0.7 milliequivalent per liter per hour over the first 24 hours, which is slightly more than what we expected, and about 0.5 milliequivalents over the next 24 hours. Because this baby remained anuric and on clinical examination later we had discrepancy in limb pulses, we suspected thrombosis. Renal Doppler showed a reduced renal blood flow to the right kidney, and you can see that the MR angio shows aortic thrombus, which is extending into both renal arteries, more on the causing complete occlusion of the right and cortical necrosis of the right kidney. The neurosonogram and the MR venogram of the brain were normal. Thrombolysis was attempted, but had to be discontinued after 48 hours due to bleeding, and low molecular weight heparin had been advised, which was continuous for about 3 months. At discharge, the baby gained weight up to 2.5 kgs, had normal urine output, had blood pressures well controlled on a single drug. The serum creatinine had returned to normal, the electrolytes were normal, and the ultrasound showed reduced vascularity in the right kidney. We recently saw this baby on follow-up at 3 months, where there was fairly good weight gain, blood pressures were well controlled on medications, the renal functions remained normal, electrolytes were normal, and there was a contracted right kidney with reduced global vascularity. To quickly review the literature, the burden of hypernatremia has been variable from 0.25 to 1.8%. A systematic review showed that among the most important risk factors, perhaps more than 10% weight loss in the first 2 weeks and issues with breastfeeding are something that can be identified and prevented early on. The burden of AKI and hypernatremic dehydration is again very variable. Various studies show a percentage ranging from 3 to 70%. The risk factors that have been quoted in most studies are a higher percentage weight loss. This is a study done by Dr. Shroff, and this had cases that were similar to ours, where they had 5 neonates, all exclusively breastfed. All babies had AKI, 2 required hemodiafiltration, 3 had extensive thrombosis that required thrombolytics. At the end of 1 year, they found that 4 had normal creatinine, though 1 had a non-functioning left kidney, and 1 baby had chronic kidney disease. This is the only article that I could find solely on dialysis in hypernatremic dehydration, acute PD, that was done in 15 newborns. The indications were similar to our study. They inserted a single cuff Tenkoff catheter. The rate of drop of sodium was what was kept in mind to be about 10 milliequivalents per liter per day. And they had significant amount of complications. About half their patients had catheter malfunctions, a quarter of them had infections, and 26% mortality was noted. The outcomes of hypernatremic dehydration per se, about 15% of them are found to have neurological sequelae at discharge, and high serum sodium more than 160 milliequivalents and a rapid drop of more than 0.5 milliequivalent per liter per hour have been found to be independent risk factors for death and neurological sequelae. From our own literature review, a published study showed that 18% of our babies with AKI had hypernatremic dehydration. This is unpublished data of about 120 newborns with AKI, where we found the prevalence to be 8%, but these babies were the ones who had the worst creatinine. So to summarize, severe hypernatremic dehydration is an important preventable cause of AKI, especially in tropical countries like ours. Controlled rate of sodium reduction is a challenge. both with and without dialysis. The indications for dialysis are typically fluid overload and refractory metabolic issues. Frequent titration of fluids based on the serum sodium is what is very crucial and must be tightly regulated. And they have a high risk of both renal and neurological failure. Thank you.
Excellent. Well done, Nivedita. Thank you for presenting this case so succinctly and well, but even bigger well done to you and your team for managing a very complex case. That's really great. So you have, as you have correctly and very nicely highlighted, the risk factors for hyponatremic dehydration are exclusively breastfed babies, in particular babies born to primiparous women, so the first baby, where the mother may not quite get the hang of breastfeeding, the breast milk output may be low, and these babies are at severe risk if they do not latch on and feed well. It's very, very important also to keep in mind, as you have said, that the neonatal kidneys are immature in their concentrating capacity. This means that even in the face of dehydration, they continue to make some urine. And therefore, if we or a midwife or a health visitor ask the mother, is your baby passing urine? And the answer is yes, it does not mean that there is no dehydration. The urine output stops only at a very late stage of AKI, and oliguria is difficult to recognize. So well done again on this case. We have one interesting question from the audience, which says, how would you interpret urine electrolytes in a neonate? Would you like to answer this, please?
So in a newborn, as we've said, the fractional excretion of sodium is what is typically done in said to be done in a baby with AKI. Here, of course, in our patient, we had anuric AKI, but as Dr. Rukshana just mentioned, most neonates are not oliguric or anuric, so they have a good urine output. This may be useful to differentiate between prerenal and intrinsic AKI, but what must be kept in mind is that preterm babies who have immature kidneys have a much higher normal fractional excretion of sodium that may, if you don't take this fact into consideration, may be erroneously interpreted. But in practical situations, what we have often found is that we can't wait for the baby to pass urine to get this test done. So invariably, before the neonate passes urine or we are able to get a sample of urine, we have already given fluids. The fluid challenge, the maintenance fluids are often started. So in clinical practice, we do not find it as a very useful tool. Most often what we use to differentiate between prerenal and intrinsic AKI is the response to a fluid challenge and of course the clinical history of weight loss or feeding and other the clinical syndrome that the baby may come with.
Excellent, thank you. And a follow-on question also from our audience is, at what age do the kidneys reach, it says adult size, but also more importantly, the adult maturity, the maturity of an adult kidney, largely in its concentrating capacity?
So the concentrating capacity, of course, in a newborn, as we've just emphasized, is extremely low, and hence most newborns with AKI do not manifest with oliguria or anuria. Usually by 1 year, they have relatively good capacity to concentrate, and as the GFR normalizes and reaches adult values by 2 years, by this time, most of the tubular functions also have normalized in terms of the glomerular and tubular functions. By 1 to 2 years of age, most of it has been achieved. The kidney size, of course, continues to increase. That's and right. Perhaps normal size of the kidney or the adult size is achieved only in adolescence, maybe about 14 to 15 years of age.
Correct. Absolutely right. And excellent. So it's the maturity that we're interested in here, isn't it, with the tubular function, which is reached really by about 2 years, but more largely by 1 year. By about 2 years, they get full adult maturity. Well done. I think we have 1 or 2 minutes. So just because this is such an important point and something fortunately we don't have to do commonly, you have mentioned it already, but do you want to just quickly take us through how you prepared the fluid, the PD fluid, to adjust the sodium concentration in it? So of course, the normal concentration of PT fluid is about 132 to 134 milliequivalents sodium. How did you adjust it for this purpose?
So we add 3% sodium chloride. So each ml contains about 0.5 milliclins. So we increase the, depending on what the serum sodiums are. Say serum sodium is about 180, then we target a PD sodium close to about 170. And we add sodium chloride to 3% sodium chloride to bring up the sodium concentration of the PD fluid to match 170 millicoulombs per liter. But of course, this is very tedious because in a few hours, we expect that the sodiums would drop and the PD fluid needs to be changed time and again. But we found that when we were not doing this, there was a very rapid drop in sodium and it was very erratic and very difficult to control. And invariably, these babies have other risk factors. For example, they could have a cortical venous thrombosis. They usually come with severe hyperbilirubinemia. They may have infections. So all these are confounding factors. And invariably, when there is a rapid drop in sodium and the baby throws a seizure, you don't know what the seizure is due to. So we found that it is better to have a controlled rate of drop in sodium, and hence we adjust our IV fluids and PD fluids to keep a rate of about 10 milliclins, where we have found that the rate drop is not very rapid.
Well done, Nive. Thank you. So just to sort of finish this bit off, we've got two important comments from the audience. In this particular situation, you had an exclusively breastfed infant who got dehydrated. Also, as the audience have correctly said, sometimes this can happen if a baby is given very concentrated formula milk. And that is a word of caution for the audience and for people to recognize as an important risk factor here as well. So thank you very much. Well done again, and let's move on. So Aditi, over to you, if that's okay. Or do you want me to do this next one?
Yeah, that's good. Go ahead. That's fine.
Yeah. Okay, sure. Then you can do Georgina as the last. Thank you. Okay, so moving on, our next, the next person, again, it gives me great privilege to have met and seen Kalaivani at work at the Metta Children's Hospital. Kalaivani Ganesan is one of the senior faculty there at Metta Multi-Specialty Hospitals. She's a recipient of many awards, including ISN grants, and is on the current executive committee of the Nephrology Association of Tamil Nadu and Pondicherry. She's a reviewer for clinical journals and an ISN and IPNA member and an author of several chapters. So Kalaivani, without further ado, welcome, and we look forward to your case. Thank you.
Thank you, Dr. Rukshana, for the kind words.
Are your slides coming through?
Yeah.
Excellent. Yeah, perfect.
Are you able to see my slides?
Yes. Yeah, I can see them well. Thank you.
It's a great pleasure in being a part of this neonatal nephrology meet. Thank you again, Dr. Sukanya, Dr. Rukshana, and the other chairperson, Dr. Aditi Sinha. So today we are going to discuss one common scenario which we encounter in our day-to-day practice. So it's a 13 days old term baby girl with an antenatally detected renal anomaly, and postnatally the baby had the stables which was vital, and other systemic examination was normal. Evaluation showed a blood urea nitrogen of 20, and the creatinine was 0.4 milligram per deciliter, and electrolytes were all normal. There was no acidosis. There was significant proteinuria with a spot protein creatinine ratio of 1.5. As it was an antenatally detected renal anomaly, we went ahead doing ultrasound on day 4 of life, with ultrasound showing right kidney of 6.2 centimeters and left kidney was 2.8 centimeters with a compensatory hypertrophy of the right kidney. And the nuclear scan revealed scar in the upper pole of the right kidney, and the left kidney was not visualized. And maturating cystourethrogram showed a grade 3 reflex. And so this is an ultrasound picture showing a non-communicating cyst which is separated by a dysplastic parenchyma. And the baby was kept on regular follow-up. On follow-up, the baby did not have any documented urinary tract infection. The blood pressure was normal. The renal function test was also normal, except for the significant amount of proteinuria, for which the baby was on enalapril. So there would be few questions on looking at this scenario. What would be the probable cause, which is involving only one kidney? So like it is a unilateral kidney. Here we confirm it is a cystic kidney disease, and which is involving only one kidney. So it is most probably a multicystic dysplastic kidney. And so usually multicystic dysplastic kidney is basically results from abnormal differentiation of metanephros, and it has got multiple cysts, which are all non-functioning cysts, and the prevalence is around 1 in 4,300 live births. So the next question what would raise in our mind in our baby is, should we do a nuclear scan or not? So nuclear scan is basically done to detect the functioning renal tissue and to assess the function of the contralateral kidney, if it has got any scars or any inflammation. And so we broadly classify cyst into inherited and non-hereditary form. Under the inherited form, you have the polycystic kidney disease, where you have the autosomal dominant and autosomal recessive type. And you have your nephronophthisis, which can be based on age of presentation as juvenile, infantile, and adolescent. You have the medullary cystic kidney disease, which is autosomal dominant, and you have few renal cysts, which is also associated with syndromes like von Hippel-Lindau disease, and you have a tuberous sclerosis and Bardet-Biedl syndrome. And our multicystic dysplastic kidney falls under a non-hereditary variant. So the next question, what would come in our mind is whether MCU is recommended in all children with diagnosed MCDK kidney. If so, what would be the percentage of reflex in a baby who is diagnosed to have MCDK? So almost 1/3 of the MCDK cases will have other associated renal anomalies. And the commonest renal anomaly would be a vesicoureteric reflex. And so the contralateral kidney, the percentage of having a reflex would be around 25 to 30%. And the next question is MCU recommended in all babies? Definitely no. You recommend MCU only when you have abnormalities in the contralateral kidney by ultrasound in form of hydronephrosis or dilated ureters, or when you have scarring by a nuclear scan, as we had in our baby, and when you have a recurrent urinary tract infection. So what are all the complications which we commonly encounter in a MCDK kidney? As already discussed, the commonest thing would be the vesicoureteric reflex, which would account for around 25 to 30%. Recurrent UTI is other possibility. Hypertension, the incidence is little low, but still the babies can develop hypertension during the course of time. And Wilms tumor is the other important complication. So next question would be, is nephrectomy indicated in all MCDK kidneys? This would be the common question from the parents' side. So the nephrectomy is indicated only when you have persistent hematuria or when you have recurrent urinary tract infection, which is actually attributable to the MCDK kidney, or when the cyst is non-involuting over time, or when you have a larger cyst which is measuring more than 6 centimeters, and instead of involuting, it is just increasing in size, then nephrectomy is indicated, or when you have a hypertension which is attributable to the MCDK kidney, though the incidence is little less with hypertension. So this is a bar diagram which shows the involution of multicystic dysplastic kidney at 5 years follow-up. So when you have a multicystic dysplastic kidney which is less than 3 centimeters, the percentage of involution would be around 90%. When it is between 3 to 5 centimeters, the involution can have around 50% can involute on its own. When it is more than 5 centimeters, the involution is little less, which will be around 20%. So how do we follow up these MCDK kidneys? So it needs regular follow-up of anthropometry in a very periodic way. You need to monitor blood pressure and keep palpating for the abdominal mass, because it can produce mass effects, or the non-involuted kidney can keep increasing in size, forming new cyst and compression abnormalities. And your routine annually, you need to follow up the protein creatinine ratio, your blood levels of creatinine. And ultrasound wise, you need to actually keep the every 4 to 6 months for the first 1 year, and yearly thereafter till involution, or you keep doing ultrasound till 10 years of age. And so our baby was initiated on enalapril, that is AC inhibitors for the significant proteinuria. So this child, because we initiated the child on enalapril, we need to keep them monitoring the serum creatinine and potassium once in 3 months. So this is a simple case. Thank you.
Thank you, Kalavani. It's a very interesting case. Simple, but a common problem we often face, and something well worth discussing, because as you have correctly said, the differential diagnosis is important, and not over investigating is important. So you've raised 2 or 3 very important points here. Can I just ask you, and I apologize if I missed this, why do you think your child had proteinuria? And a follow-on question with that, at what age did you start the enalapril?
So we started enalapril around 2 years of age. So we there was a compensatory hypertrophy. Like usually the compensatory hypertrophy is around more than 2 standard deviation for the growth, and it should be attained by 3 years of age.
Good, excellent. Thank you for that. So just an important point for the audience as well, enalapril should not be started in the neonatal period, definitely not for the first 6 weeks, and ideally it's unlikely it will really help in the first few months. An important thing is all babies everywhere in the world will have diarrhea and vomiting at some stage, and therefore they are at risk if they're still on enalapril in the face of severe volume depletion with diarrhea or vomiting. They will be at risk of a neonatal AKI, of an AKI, not neonatal, an AKI. So be very careful with the enalapril use in the very young ones, and never use it below about 3 months. Yeah. Kalavani, another important point you raised is the age at which nephrectomies may be helpful, and exactly based on the study you showed us in pediatric nephrology, in our unit as well, it's a very simple rule of thumb we follow. If the MCDK is more than 6 centimeters at 6 years, do a nephrectomy, which is exactly what you have said. Yeah. How often have you in your practice seen complications from MCDK?
Hypertension, we have not encountered much, but proteinuria is quite significant, and we had initiated the child on enalapril. Other than that, Wilms tumor, I don't think I have ever seen.
No,
Reflex, we have quite often seen.
Correct. So that's just checking that the compensatory kidney is normal. So exactly as you have said, and it is exactly for this reason that sometimes a VCUG or MCUG is performed if there's any doubt that the contralateral kidney may not be normal. Yeah, good. Yeah. There are 1 or 2 questions here repeating, asking how early can a DMSA scan be done? How early can it done, or should it be done?
It should be done only after 3 months of age, because the cortical maturation happens only after 3 months. Till then, you're not supposed to do by rule.
Excellent. Well done. Well done. And I think that covers most of the questions we have. And you gave a very, very nice talk on differential diagnosis and management plan. So thank you again. Well done. And we'll move on to the last case in this series. Thank you.
Thank you.
Aditi, over to you.
Thank you, Professor Shroff. So we move on from a case which had mild proteinuria to something that causes massive proteinuria in newborns. And to present this case, we have with us Dr. Georgie Matthew. I had the pleasure of introducing Georgie, who is a favorite student of ours. He has recently left the institute after completing his DM in pediatric nephrology at All India Institute of Medical Sciences to return to his alma mater, that is Christian Medical College, Vellore, where he is a faculty now. Over to you, Georgie.
Thank you, ma'am. I will start with the commonest introduction that
we have heard over the last 2 years. Is my screen visible and am I audible?
Yeah, you're audible, but your screen and your face aren't visible.
Right.
I think the screen's about to appear. Yeah, we can see you.
Okay, I would, good evening, everybody. First of all, I'd like to thank Dr. Sukanya for inviting me for this presentation. And I have been given the unenviable task of, holding a light to the sun by giving me a topic of congenital nephrotic syndrome, discussing a case of congenital nephrotic syndrome right before a lecture by one of the leading scientists on congenital nephrotic syndrome. Without much further ado, I will go on to the presentation. So we have a 6-week-old infant, so technically not a neonate, 6-week-old infant who presents to the immunization clinic and asks the pediatrician over there, notice mild periorbital puffiness. And the mother casually mentions that this is present right from delivery, right from his early infant neonatal life onwards. So you undress the baby and then you get ascites, there is pleuritic edema, there is with the normal cardiorespiratory examination, and there is no organomegaly. So in this scenario, how do we proceed? So as common in any patient with edema at any age, commonly as we know, edema is because of simple Starling's forces are lie behind the pathogenesis of edema. It's either fluid accumulation because of oliguria, because of kidney disease, or congestive cardiac failure, or hypoalbuminemia because of renal loss, GI loss, or sepsis or severe malnutrition. Then rare causes like anaphylaxis, then severe congenital hypothyroidism, lymphatic edema, and eye drops may be the causes in a neonate or infant. So in this infant, we suspect a possibility of a congenital nephrotic syndrome. So what all do we look at in a patient who is suspected congenital nephrotic syndrome? When we look through the literature, we find that children with congenital nephrotic syndrome do have a history of being premature, and it was seen in almost more than 80 to 90% of older literature case series that median gestation age was 35 to 36 weeks, and the birth weight was 2.5 to 2.6 kg, which is low by the European standards. Another important feature that we are all taught, and it is commonly seen in children with congenital nephrotic syndrome, is the placenta to infant infant weight ratio. The birth weight ratio is usually about 18 to 20% in normal neonates, while in congenital nephrotic syndrome, it is because of placental edema, it is usually more than 25% of the newborn weight. And in an older case series of the classical Finnish nephrotic syndrome patients, it was seen the median placental to infant birth ratio of about 38 to 40%. We know that these children are diagnosed in the first week, but some children may even be diagnosed antenatally with the presence of fetal edema, oligohydramnios, and increased nuchal translucency. So in a child with congenital nephrotic syndrome, as we know, this is the nephrotic syndrome in which we have the highest yield of genetics. And so the highest etiology being genetic workup, there is a high risk of, in consanguineous marriage, there is a high risk of nephrotic syndrome in these children. We do ask for the history of family history. Quite rare causes like secondary causes of congenital nephrotic syndrome may be there, like maternal lupus, malaria, syphilis. Those scenario we need to look at in our history, and close examination of the baby is warranted with special attention to dysmorphism. Neurological examination formed a major chunk of extrarenal manifestations in congenital nephrotic syndrome, with hypotonia, microcephaly being important clinical features. There are some musculoskeletal skin manifestations, genitalia, but ambiguous genitalia in WT1 mutation, and some rare other genetic diseases do point out towards definitive etiology, and it may warrant detailed examination and monitoring. It also has a role in monitoring and prognosis. So I'm not elaborating much on the extrarenal manifestations because the paper referenced here has
extensive 2-page table with all possible list of extrarenal manifestations with the genes associated with it. So I would urge all of you who are listening to especially look at this paper for further reference. So all these children do mandate a hearing and eye examination, also cardiovascular examination. If it reveals any findings, we should go for echocardiography and the other investigations. Okay, now that we have suspected congenital nephrotic syndrome, so what do? So we go ahead and work up this child for the presence of a nephrotic state. So we find normal renal functions with severe hypoalbuminemia, hypercholesterolemia, and nephrotic range proteinuria. Maybe for our protein collection may be difficult in a neonate or infant like this. So we do a urine protein creatinine ratio and it shows massive amount of proteinuria. So we have established the nephrotic state. So what is the next line that we all can do? So as we have already mentioned before, congenital nephrotic syndrome is just one diagnosis of an infant or a neonate with edema. So we need to make sure that the other causes of edema are not there either by clinical or laboratory investigations. So the predominant investigations that we may do are listed in this slide. So thyroid function tests are very important. Then, because these children lose a lot of thyroglobulin and other proteins, they do have an amount of hypothyroidism, and also sometimes rarely severe congenital hypothyroidism. Children with TSH of more than 1500 or 2000 that I have seen do come with mild amount of edema, and also maybe 1+ or 2+ proteinuria. So thyroid function tests form an important part of our assessment. Then we look at some secondary causes like CMV, toxoplasmosis, and syphilis, which are common. Malaria is seen as a cause of nephrotic syndrome in endemic areas. The hepatitis B and hepatitis C, herpes simplex, HIV are extremely rare. And as far as I know, HIV may not have been reported for a cause of congenital nephrotic syndrome. In very rare cases, we may look at ANA-C3 and neutral endopeptidase antibodies for a membranous type of nephropathy. Amino acid levels to look at glutaric aciduria and diseases of sialic acid metabolism. They form maybe a tier 2 or tier 3 investigations if these first tier investigations do result in a negative study. One important question that is asked these days is the use of renal biopsy in children with nephrotic syndrome. Earlier, in maybe 25-30 years before, many children with congenital or infantile nephrotic syndrome used to get a biopsy. This was ridden with complications. And now with the current availability and feasibility of genetic testing, I do feel, and I think it is a common practice, that renal biopsy has taken a backseat. It may be a second, third, or fourth tier investigation when there is no results from the initial investigations and genetic testing. This comes to the elephant in the room, which is the genetic testing. I will go into the genetic testing in the upcoming slides. Before going to genetic testing, I would like to dwell in the main issues of management. So now that you have established the nephrotic syndrome present in the patient, so what all are the general principles of management? I'm not going into great details of management because many of you are well versed with this, I'm sure Dr. Olivia will enlarge upon this general principles of management. Like Dr. Rukhsana mentioned in the previous, the major problems in children with nephrotic syndrome is edema, and edema control is predominantly attained with daily dose of diuretics and albumin. Like Dr. Rukhsana mentioned in the previous presentation, children, especially infants and neonates, do tend to get diarrhea very often, or are prone for dehydration. Hypovolemia should be used with very good care. Adequate instruction to the parents regarding sick day management need to be mentioned. Albumin is usually used as intermittent infusions of 0.5 to 1 gram per kg. Literature mentions even doses up to 4 gram per kg being given in children with severe edema. These may be mentioned on an outpatient basis in our Indian scenario, and in some countries there are even children who have a central venous access placed, and home albumin therapy or nightly albumin therapy is being practiced with some success. Then comes the issue of thyroid hormone replacement. As I already mentioned, neonates or infants require higher dose of thyroxine, as we all have learned in our pediatrics. Another cornerstone of therapy is the antiproteinuric therapy, which is predominantly driven by the ACE inhibitors or ARBs, where captopril, because of the short half-life, is used commonly, and especially Dr. Schroff mentioned in the previous presentation, these are to be used after the neonatal age group. People also use prostaglandin inhibitors for control of proteinuria by reducing the GFR. One word about the diuretics is the first line diuretic, as we all use, is furosemide or Lasix. But if a potassium sparing diuretic is to be used, recent guidelines mention that ENaC inhibitors like amiloride are maybe better than spironolactone in view of their plasmin inhibition activity. So the other major issues are of anticoagulation, which I have a small question on for the question. Then vein preservation and nephrectomy for future management. In the current in the previous era, bilateral nephrectomy used to be common when children achieve 7 to 8 kgs of weight and initiate dialysis. And this practice has recently evolved, and some literature even mentions that even unilateral nephrectomy may reduce the protein load, and that may be enough to, and the remaining kidney can help in some bit of fluid management. So the last guideline mentioned that nephrectomy may be done at CKD5 or if there are other problems in the patient. When we should also do not forget some specific therapies which are available for congenital nephrotic syndrome management in case these etiologies are present. So in case of mitochondrial diseases and CoQ deficiencies, CoQ replacement, coenzyme Q replacement can be used. The syphilis can be treated with penicillin and other antibiotics. Cytomegalovirus, active cytomegalovirus can be treated with ganciclovir and valganciclovir. And as is usual with all forms of chronic kidney disease and even congenital nephrotic syndrome, when children grow up to become adequate age, we support them with renal replacement therapy when the kidney fails, including peritoneal dialysis, extracorporeal dialysis, and finally, it should be topped up the final step with renal transplantation. So just one small question regarding this one. The answer is there on the slide, so I'm not going into great ecstasies about this. So if these infants do have generalized seizures, like with any infantile seizure or neonatal seizure, we check for calcium, magnesium, glucose levels. We should do not forget this high incidence of thrombosis, and there may be some CNS malformations in children with congenital nephrotic syndrome. So coming back to genetic testing or genetic basis of congenital nephrotic syndrome. So this is a diagram or cartoon that we are all familiar with, the podocyte and the slit diaphragm and the glomerular basement membrane and multitude of proteins associated with it. So more than 70 genes are currently considered as etiologies for steroid-resistant nephrotic syndrome or a difficult congenital nephrotic syndrome. There is a consensus that 4 of these genes do cause more than about 80 or 90% of all the congenital nephrotic syndrome. And next generation sequencing is, if it's available, we can use that. Otherwise, we can use this initial panel. And if that is negative, then go for next generation sequencing. And then currently it is, and would be an understatement to say that genetic testing is essential for counseling, diagnosis, management, and prognosis in all our patients. So when we look at the scenario from India, so over the last so many years, we do have 2 multicentric studies with a population of about 100 patients from our country, in which about 50 patients were had genetic testing, and it follows the common pattern that 53 and 74% had NPHS1, and the 4-gene panel will give you a positive result in about 70 to 80% of the patient. So there is an interesting new variant in the NPHS1, which is a speculative fundamental variation in the latter study. So the references are given below. So I urge the audience to go and have a look at these references. So these are useful to know the scenario of congenital nephrotic syndrome in India. So what all are the other features observed in Indian children with congenital nephrotic syndrome? So microcephaly was observed quite common in both the studies. Torch profile was common. The important thing to note is very poor response to therapy, either with some patients have been given corticosteroids. Most people have been on conservative therapy, and very few patients have been given immunosuppression. But despite all therapy, the remission rates are poor, as we all know, and we can see in the literature. Mortality is quite high, with sepsis being the chief culprit, and many children do pass away even within 3 months of age or even diagnosis of nephrotic syndrome. And a significant portion is lost to follow-up because they know that it is difficult to manage these children, and these are often presumed mortality in situations. In renal transplant, because these children don't grow up to become that age, and they succumb to infections or other illnesses in the interim period. So there is one renal transplant recorded in this entire patient, and I also personally know of another one patient who grew up till 5 years of age, but he succumbed during his preparation, during his renal replacement therapy. So what all are the problems faced by children in Indian scenario? So if you look at the numbers, only about 100 patients with congenital nephrotic syndrome have been published as part of large studies, or genetic studies have been done. So imagine the population of India, the number of births, and if you can see, even with normal nephrotic syndrome, studies with patients, 100 patients, 200 patients have been published, but overall, for so many years, only 100 children with congenital nephrotic syndrome are published. So you can see how much of this scenario is underreported, either because of pediatrician awareness or early diagnosis, or in high mortality rates, or because of referral. And these children do find, even those who find access to healthcare, find it very expensive to continue albumin infusions and care at tertiary care centers. As we all know and are aware of, tube or gastrostomy feeding are have not calculated to the general pediatrician. The parents also are not very aware of the benefits of these practices. So that is also one important point, with children lagging behind in nutrition and having the complications because of malnutrition. Infections run rampant in our scenario. Then even genetic counseling or genetic testing has also, if currently it is much more prevalent than the scenario maybe 2 years or 3 years ago, and it is yet to spread at quite a rapid rate in all these patients with genetic diseases. And renal replacement therapy usually, is a distant dream for these children or small babies with congenital nephrotic syndrome. I would like to end my talk right here and take questions if any. Thank you.
Thank you, Georgie, for that very nice talk and elaborate discussion particularly about the Indian context. We'll be hearing about more on congenital nephrotic syndrome soon after this conclusion of this discussion. In the interest of time, I would ask you to quickly take one of the two questions, because I guess the second question would anyways be addressed in the context of the talk. So one participant delegate has asked whether you would want to use steroids in the management of nephrotic syndrome of congenital kind.
So currently, as we know, steroids is a cornerstone of management of normal, our regular, bread and butter nephrotic syndrome. But however, in this scenario, as I've mentioned in this slide, more than 80% or 90% do have a genetic etiology. And in the current study, if you can see, 89% had a genetic etiology, which are usually non-responsive to steroids. However, in case, because of variation in practices from physician to physician, some physicians may feel, and some because of the pressure from parents or otherwise, they may feel compelled to use steroids. But however, it is not general practice, and usually they more often than not they do not respond to corticosteroids. And if you ask me personally, I usually would not start on congenital nephrotic syndrome patient on corticosteroids.
So with that, I think we would like to conclude this session. Thank you, Georgie, and thank you, the organizers, for allowing us the option to chair this session jointly with Professor Shroff. Thank you, Professor Shroff. I'm sure the next question would anyways be taken in the next talk. Thank you.
Thank you.
After this very informative session, we now move on to the next session, which will be the third as well as the last session for the day. This session is on challenging renal problems in neonatal ICU, and this session will be chaired by Dr. Uma Liman. She is a consultant pediatric nephrologist at Leelavati Hospital and Research Center, Mumbai, and also Jupiter Hospital, Thane. She is head of nephrology department at SRCC NH Children's Hospital, Mumbai. She's been the former dean, BJ Wadia Hospital for Children, former head of pediatric nephrology and PICU team, BJ Wadia Hospital. She has been a former counselor of India for IPNA and Asian Pediatric Nephrology Association. She's been awarded 9 orations totally, including the prestigious PM Udani oration. She has Lifetime Achievement Award by the IIP Pediatric Critical Care Chapter and has more than 24 publications in her name. Over to you, ma'am.
Thank you. Hello. Yeah. Thank you for giving me the opportunity to chair this session. I think we come to the rare section of neonatal problems, which are not often discussed, and we don't see so many to develop a good expertise in it. And we have Dr. Olivia Boyer, who's a pediatric nephrologist at Necker Hospital in Paris, and also a professor of pediatrics at the University of Paris in France. She's also has a Master of Science in Physiology and a PhD in Genetics. And she's in charge of the clinical services in pediatric nephrology, dialysis, and transplantation, which is also a leading hospital in France for rare diseases in children. She's won several awards, including the René Habib IPNA Award. And she's a member of many important associations and committees, including IPNA, and chair of the Best Practice Committee, and board member of the ESPN Glomerulopathy Working Group. And she has recently published, along with her colleagues in ESPN and ERK, a consensus statement on the management of congenital nephrotic syndrome. So we welcome you, Dr. Olivia, to deliver your lecture.
Thank you very much for the kind invitation. Can you allow me to share my screen, please? Thank you. Okay. So let's start with a little of background. As Georgie just said, congenital nephrotic syndrome is defined by nephrotic range proteinuria and edema manifesting in utero or during the first 3 months of life, rarely caused by congenital infections or maternal alloimmune disease. It is mostly due to podocyte gene pathogenic variants, with NPHS1 pathogenic variants being the first cause worldwide, followed by podocin gene variants, and WT1, LAMB2, and PLC1 rare variants. So you know that these kids are prone to severe complications such as hemodynamic instability, recurrent infections, thrombosis, and impaired growth. And most children with congenital nephrotic syndrome progress to kidney failure within a few years. In the 60s, the mean survival was reported to be 7 months, with most children dying owing to infections, hemodynamic collapse, or thrombosis. This disease was previously known as the Finnish type nephrotic syndrome due to its high incidence in Finland, with 2 founder variants called Fin major and Fin minor underlying most cases, whereas in the rest of the world, more than 200 variants have been identified along with other gene variants. So in the 80s, an aggressive management consisting of daily albumin infusions on a central venous line with prevention and management of comorbidities, and most importantly, preemptive bilateral nephrectomy at a weight of about 7 kilos with dialysis, mostly PD, and then kidney transplantation when the child's weight is around 9 kilos was proposed. And this led to a tremendous increase in life expectancy, because with this treatment, more than 90% of the children are now transplanted with a similar patient and graft survival to other transplanted children. But more recent data, including a large nationwide French study and a European studies of several centers participating to the dialysis working group and led by Rushan Ashraf, reported the successful treatment using a more conservative approach involving optimized nutrition and medications, but without preemptive nephrectomy. And therefore, the European Society of Pediatric Nephrology and ERCNet embarked in a guideline project to update the guideline for management of congenital nephrotic syndrome. And that was published in two parts, one on the general management and diagnosis published in Nature Reviews Nephrology, one on the genetic aspects of congenital nephrology published in European Journal of Human Genetics. Both are open access and freely downloadable. And a longer version of this webinar is also watchable on the ERCNet website. So here is the guideline that we propose, and I will guide you through it step by step. So the diagnosis workup that we recommend was detailed by Georgie previously, and we have to record the family consanguinity, history of CNS, prenatal and perinatal history, the amniotic fluid alpha-fetoprotein, placental weight, and then the first-line physical examination should aim at assessing the volemia and edema for the urgent management, followed by general blood chemistry to look at the complication of congenital nephrotic syndrome, as well as dietary assessment. Then, as Georgie said, an extended evaluation will look for the syndromic forms of congenital nephrotic syndrome with a search for dysmorphia, skeletal, genital, ophthalmological examinations and hearing tests, and a full neurological examination. And this should be completed by infection screening and in some instances, immunological tests. So if congenital infection is diagnosed, then a specific antimicrobial agent should be used in these children. Otherwise, if infectious screening is negative and the family does not suggest congenital membranous nephropathy, then the children should be treated as genetic congenital nephrotic syndrome while waiting for the results of the genetic testing. So, as was said, we recommend a comprehensive genetic screening comprising all podocytopathy-related genes in all children with congenital nephrotic syndrome and providing genetic counseling promptly. And this can be done either if there is a population-specific defect, such as NPHS1 variant in Finland, or a clear phenotype suggestive of a clear variant, such as Dennis-Drash syndrome with WT1 variant. Then a specific genetic screening by Sanger sequencing may be performed. In all other cases, we recommend next generation sequencing techniques such as podocyte panel or whole exome sequencing. But if it is not available, we recommend at least to test for these 4 gene variants, NPHS1, NPHS2, laminin beta 2, and the exon 8 and 9 of WT1 genes, because these genes will uncover more than 80% of the cases. And of course, if this is negative, we recommend to go for NGS. So then, if a specific variant is identified, we recommend a specific management, such as in the case of WT1 variant. We recommend karyotype testing in each patient with ambiguous genitalia or in each phenotypic girl, because it can be a complete sex reversal in the kids. We also recommend evaluation for urogenital malformation and an oncological surveillance for Wilms tumor and gonadoblastoma with an abdominal ultrasound performed every 3 months until the age of 7 years. We recommend bilateral nephrectomy at time of end-stage kidney disease due to the risk of Wilms tumor, and bilateral gonadectomy in 46 XY phenotypic girls with complete gonadal dysgenesis, as well as endocrine and psychological management. So another specific management is the coenzyme Q10-related mitochondriopathies. And in these cases, we recommend complete and repeated screening for extrarenal manifestations. And if the genetic screening is non-informative, muscle, skin, or kidney biopsies may be needed to confirm the diagnosis. In these cases, early coenzyme Q10 supplementation may improve the proteinuria and sometimes the neuromuscular complaints. So as Georgie said, the vast majority of genetic congenital nephrotic syndrome will never respond to steroids nor to other immunosuppressive treatment. And therefore, we do not recommend to use these immunosuppressive regimens in children, but rather to use RAS blockades and other preventive measures. We do not recommend routine kidney biopsies in these children because the non-invasive genetic screening will identify the underlying genetic abnormality in more than 85% of the patients. But we suggest to consider performing kidney biopsies in patients with sporadic non-syndromic disease with negative tests, or if the GFR is below 30 milliliter per minute, because it can identify other causes of congenital nephrotic syndrome, such as membranous nephropathy. So let's move on to the management. So as a preliminary remark, I would like to highlight that it was not possible to write a unique protocol for all these kids because CNS encompasses a wide spectrum of clinical phenotypes that should be managed with different approaches. So some children may have no or minimal symptoms and should be spared aggressive and potentially harmful treatments. But others will have massive proteinuria, anasarca, and hemodynamic compromise, and they should receive daily albumin infusion on a central venous line and intensive symptomatic treatment. So therefore, the management should be adapted to the clinical severity of the condition, aiming at maintaining the intravascular euvolemia and adequate nutrition, as well as preventing complications. So when possible, we recommend avoiding central venous lines due to the high risk of thrombosis, but if the line is required for repeated albumin infusion, we recommend administering prophylactic anticoagulation as long as this line is in place. We also recommend general vascular preservation for future hemodialysis access, including avoiding peripheral catheter and unnecessary venipuncture. So in general, we recommend avoiding intravenous fluids and salines in those kids. The oral fluid intake may have to be concentrated if necessary to avoid marked edema with the help of an expert renal dietitian. We recommend salt restriction in all children with edema, but fluid restriction only in case of hyponatremia or in the most severe cases of edema. So one of the most tricky recommendation that we had was on albumin infusions, because some centers do offer albumin infusions to all children with CNS, whereas others do not. But what we agreed on was that we should not base our indication of albumin infusion on serum albumin levels, but rather on clinical indicators of hypovolemia, including oliguria, AKI, prolonged capillary refill time, tachycardia, hypotension, and abdominal discomfort, or upon failure to thrive. The potential advantages of regular albumin infusion are to support growth and psychomotor development and stabilize intravascular volume and minimize edema, but the disadvantages are the need for a central venous line, the increased risk of infection and thrombosis that may endanger future hemodialysis access, and the prolonged need for hospitalization and associated costs, with impacts on quality of life and school attendance. Moreover, I do not have time to go into too many details, but the most recent European series showed that some children do well without any albumin infusion, and that was the case in 5% of the recent European series. In other, the albumin discontinuation is possible and was safe before nephrectomy. That was the case in 20% of the French cohort and in 5 children from Newcastle at an age ranging from 1 to 29 months for up to 4 years. In other, the albumin that was initiated could be safely tapered, and this was the case in the European series, especially after introduction of ACE inhibitors. Roxana could show a 70% increase in serum albumin with reduction of the weekly albumin infusion dose after introduction of this treatment. Moreover, there are some rare cases of spontaneous remission, and therefore an ambulatory management is possible before nephrectomy in a large subset of cases. So to sum up the recommendation for albumin, in case of hypovolemia or failure to thrive, daily albumin infusion may be initiated, and in stable patients or when the CKD progressive, albumin dose may be reduced and infusion may be subsequently be less frequent or even stopped. In case of severe edema, we recommend using diuretics in patients with signs of intravascular fluid overload, evidenced by good peripheral perfusion and high blood pressure and edema, and preserve kidney function, but not in case of intravascular hypovolemia. The infusion may be slowed to minimize ototoxicity. And in case of moderate edema, we recommend to avoid centrovenous line and maybe to consider oral diuretics. So in all children, we recommend, as other measures RAS blockade, but as was said, we do not recommend to start this treatment before 4 weeks of age, and then to balance the benefit to risk ratio, because some children will not respond to ACE inhibitor. And we suggest starting with a short-acting ACE inhibitor captopril, and do not recommend combining ACE and ARBs due to the high risk of AKI. In case of poor responsiveness, we may add indomethacin dose incrementally, but we recommend to stop this treatment if no apparent benefit has occurred after 2 to 4 weeks, meaning a raise in serum albumin level or a decrease in edema. In case of vomiting or diarrhea, RAS blockade, indomethacin, and diuretics must be stopped due to the high risk of intravascular volume depletion, thrombosis, and AKI. The other preventive measures include preventive anticoagulation during the states of increased thrombosis risk, such as hypovolemia or when a CVL is in place, and or in a child with a prior thrombosis. We do not recommend antibiotic prophylaxis, but rather a prompt antibiotics if a bacterial infection is suspected. We recommend vaccinations at large, including vaccinating against the encapsulated bacteria and VZV and influenza vaccine annually, and IVIGs in patients with low IgG levels and recurrent or severe infections. In the case of exposure to chickenpox in non-immunized children, specific VZV IVIGs can be given, or at least oral acyclovir. And if the child developed a real VZV infection, then we recommend giving high-dose IV acyclovir. We recommend a high energy and protein diet, but with low salt content, with the help of an expert dietitian. And the other preventive measures include iron, EPO, calcium, vitamin D, levothyroxine, and growth hormone when appropriate. But there is insufficient evidence to recommend treatment of dyslipidemia with lipid-lowering agents in such small babies. Then we do not recommend performing routine early nephrectomies in children with congenital nephrotic syndrome because, as I said, in the most recent retrospective study, we do not find any difference in the CNS complication with these two strategies, including the risk of CVL-related infections, of septic episodes, whatever the cause, or of thrombosis. And the reported cases of death in this disease were mostly reported after reaching end-stage kidney disease while on renal replacement therapy, whereas it was very low during the conservative management. And moreover, with other long-term complications of CNS, such as growth, then the European series did not show any difference in terms of height when the kids were managed conservatively or with early bilateral nephrectomy. So in stable children, we rather recommend ambulatory management to increase the quality of life, decrease the risk of nosocomial infections, and reduce the treatment cost, and then spacing out of stopping albumin infusions if given. We recommend to consider early nephrectomies only in case of persistent severe congenital nephrotic syndrome with hypovolemia, thrombosis, or failure to thrive, despite the optimized management. And we also recommend performing these nephrectomies before kidney transplantation at time of end-stage kidney disease if there is a persisting nephrotic syndrome or in case of a WT1 pathogenic variant due to the risk of Wilms tumor. The dialysis should follow the general guideline for dialysis in children, and all families should be offered genetic counseling prior to parental kidney donation, with bearing in mind that the carriers of heterozygous variants in an autosomal recessive gene can be kidney donors, but mind that there is a large intra and inter-family variability and age-dependent penetrance with dominant traits such as WT1 or in case of NPHS2 variants, and so that should be addressed before proceeding to parental kidney donation. So I would like to thank all my friends from the ESPN and EarthNet working group that participated to this project, the external expert group and voting panel, you for your attention, and I will be very happy to take any question.
Yeah, thank you so much for the excellent talk. I mean, you managed to convey so much in such a short period. I think what we'll do, we'll take all the questions at the end of all the three talks, although the talks cover different topics. So we'll go on to the next speaker and talk on neonatal hypertension, which is an even less understood entity, because I think a lot of us miss the diagnosis because we don't recognize the hypertension and what values to use, and always difficulties with the management. So I invite Dr. Janice Dial, a clinical associate professor in the University of British Columbia, medical director in pediatric kidney services and BC Renal president of Canadian Association of Pediatric Nephrologists, Division of Nephrology, BC Children's Hospital, Vancouver. And she's a member of the Hypertension Canada Guideline Committee and the International Pediatric Nephrology Association. I invite Dr. Janice to deliver her lecture.
Thank you. And thank you for inviting me to speak on this topic that I enjoy. Oh, not the screen to share. Let's try that one. All right. All right. So to start with, I don't have any conflicts of interest to declare. And of course, unfortunately, all medications I'm going to mention are off-label use in neonates, as I think you're probably used to. So I wanted to cover three main objectives today. So to start with, to appreciate the challenges of accurate blood pressure measurement in neonates, which is why I think this topic is a challenge to most clinicians. I want you to understand the differential causes of elevated blood pressure in the NICU, and then be able to appropriately investigate and manage confirmed cases of neonatal hypertension. So in terms of methods of blood pressure measurement, our gold standard continues to be direct measurement with intra-arterial lines, either umbilical, radial, or others in neonates. Obviously, this carries its own risks, and so it's saved for the most sick, unwell, unstable infants in the NICU. So a move to much more use of indirect measurements with sphygmomanometers. Now, the kind of measurements we would do in older children are not practical in the NICU, such as palpation and auscultation. If you are trained in ultrasonic Doppler, then you can use that to get accurate measurements in the NICU population, although you're more likely to catch a systolic blood pressure than you are a diastolic one. So there's a big move to using the oscillate metric devices much more in the NICU setting. So in one of my roles, I'm the co-chair of the hemodynamic adaptation work group of the International Neonatal Consortium, a big mouthful. So on this committee, we are trying to help with setting up standards of measurements of blood pressure and assessment of blood pressure in neonatal studies so that the future studies are done with consistent methods and we get better quality future studies of this. So our first task was to try and go through the proper methods of measuring blood pressure. So we did a systematic review looking at all of the different, so on the left, these are all of the different studies or sub-studies looking at comparing intra-arterial measurements, the direct measurements, to indirect measurements in the form of oscillometric, and all of the studies that used Bland-Altman methods to do the comparison. So here on the bottom, you can see that 0 would mean that the average of all of their direct measurements were the same as the average of all of their indirect measurements. And so this is the plot for the map. And as you can see, there's quite a splay of what the average measurements are, some further away from the red line than others, but it's fairly equally distributed on the left side and the right side. Unfortunately, what you can also see is that the standard errors are quite large on this, meaning that in many of these studies and in many of these infants, the oscillometric method is not being a good representation of the intra-arterial. When we looked at systolic blood pressures, there was fewer studies. And from this slide, you can see that there's more of the means that are over onto the left side, which is suggesting that the oscillometric methods is overestimating your blood pressure systolic compared to the direct measurements of umbilical lines. Diastolic looked fairly similar to this systolic plot. So to remind you, the oscillometric devices are actually measuring maps. So as the cuff inflates, it's watching the pressure oscillations in the vessels, and where it's maximum is the map. Then each specific device has a different algorithm that calculates systolic and diastolic. So it's really only measuring map. And every different device has a different algorithm, so slightly different values can come from different ones. In almost all of the studies, the devices will overestimate MAP, or blood pressure, when the MAP is less than 30. And so MAP is our most accurate, systolic and diastolic overestimate. I get a lot of questions about what about calf blood pressure measurements. So the systolic by calf is lower than the arm up until about 6 months of age, but it's much more variable, and our blood pressure standards are based on our arm measurements. So it's not something that we routinely recommend. I appreciate there are situations when there are certain lines in arms and limbs that can't do it, but it's harder to interpret. And the other very important thing about blood pressure measurement is making sure that you use the proper cuff size. And so based on our systematic review, we recommend a cuff width to arm circumference ratio of about 50%. And I'm not sure that all nurses in the neonatal units actually understand what that means. So we included an illustration. So when you're talking about a cuff bladder width, it's actually holding the cuff up the opposite way that you would before you'd put it on the arm to measure, to make sure that the width is 50% of the arm circumference. And then you turn it around the way that you're going to use to put on the arm. And that's a proper way to check the size. And my recommendation to the pediatric nephrologists is to get used to talking in MAP. So the intensivists are quite comfortable talking in MAP, the neonatologists are quite comfortable, and the nephrologists who are used to doing manual blood pressures usually speak in systolics, diastolics, but if we're using an oscillometric method, we should get used to talking in MAP because that's what the device is actually measuring. We also produced a series of recommendations from the International Neonatal Consortium about proper methods for blood pressure. So here again, the cuff, using a cuff width arm circumference ratio closest to 0.5, use the right upper arm for the oscillometric methods in case of coarctation of the aorta. To use, as in the similar to the AAP recommendations, we said that you can use oscillometric devices to screen for blood pressure abnormalities, but if the values are too low, too high, don't correlate with the condition of the infant, then you do have to get intra-arterial values to confirm them. When you do use oscillometric devices, use MAP as your most accurate one to compare to normal values. Use repeated measures because a single value can be quite variable, and if you're going to change your management decisions, you want to be quite certain about the value you're using. And in general, for both clinical care and research, a kind of standardized protocol, including those recommendations, should be used when you're trying to see whether it's a proper blood pressure measurement and if you need to do anything different management-wise. So what about neonatal hypertension? Well, the incidence of hypertension really depends on how it's been defined. Some of the early studies used threshold values as cutoffs to try to define hypertension. More recent studies are using the 95th percentile. We really have no hard outcome studies to say which is the proper method to use and what is the proper threshold to use. In general, I think most people are using a blood pressure that's consistently above the 95th percentile for postmenstrual age. Neonatal hypertension is very uncommon in healthy newborns, estimated at about 0.2%. And in most of the studies in the NICU, it's been a fairly consistent incidence of about 1 to 2%. Surprisingly, it hasn't been increasing over time, despite all of the advances in medical care. It often presents in the first 1 to 2 weeks of life, but there is a second peak in infants with chronic diseases. And you would want to compare them to the blood pressures by postmenstrual age. So this is a table that we have in one of our review articles showing by postmenstrual age, the systolic, the MAP, and the diastolic for 50th percentiles, 95th, and 99th percentiles. Although with the rates not increasing, it could possibly be because there's a lot of underdiagnosis of neonatal hypertension. So this is a recent study by the Awaken group. So it's a multi-center retrospective cohort study, and they just looked at their cases of hypertension and found a whole cohort rate of about 1.8%. But when they looked at the actual charts of all of these individual patients, they found that undiagnosed hypertension, which they defined as more than 50% of the lowest readings above the 95th percentile, there was probably another 3.7% that were undiagnosed. So this is my clinical pearl for the risk factors for hypertension. So preterm hypertension is almost always related to perinatal events, and term-related hypertension is almost always due to an underlying condition. So of all infants with hypertension in the NICU, 75% of them are going to be premature, and they are the sicker infants, ones with higher severity of illness scores, lower coexisting diagnoses, longer hospital stays. The risk factors are all of the NICU-related three-letter acronyms, so umbilical artery catheters, use of antenatal or postnatal steroids, intraventricular hemorrhage, chronic lung disease, which is one of those ones that presents later on in follow-up, patent ductus arteriosus. ECMO in neonates is strongly associated with a high incidence of neonatal hypertension, asphyxia, seizures, necrotizing enterocolitis, neonatal abstinence, and certainly in the renal failure and congenital renal anomaly population. So there's a very long list of potential causes of neonatal hypertension. In general, the big categories are renal vascular, renal parenchymal, which can be congenital, it can be acquired or associated with urologic anomalies, it can be acquired, heritable. Then the next big sections are cardiovascular and respiratory. It can be neurologic, endocrine, neoplastic, related to medications either given to the mom or the infant, and a host of other causes. But you don't have to know this big list. I've also created a list that breaks it down into what's common. So common things being common: renal vascular causes with renal artery thrombosis, renal artery stenosis, or renal vein thrombosis. Renal parenchymal is also a very common cause. So whether it's congenital problems like renal dysplasia, hypoplasia, or polycystic kidney disease, it may be associated with a urologic anomaly that's like an obstructive uropathy or UPJ obstruction. Could be acquired like acute tubular necrosis or cortical necrosis from some of the events within the NICU. In the cardiovascular, common causes, so it could be coarctation, a PDA or ECMO. Respiratory, most common cause is chronic lung disease, and then neurologic, it could be related to pain, seizures, intracranial hypertension. And in terms of drugs or medications, the most common culprits are steroids, adrenergic agents, caffeine, theophylline, excess salt, or saline. So what about investigation of hypertension? Well, I actually quite enjoy neonatal hypertension because you've got a kind of small compact list of potential investigations that's probably going to catch the majority of issues. So basic serum electrolytes can tell you about renovascular causes, renal, endocrine causes, and heritable hypertensions, renal function to tell you about renal and renal vascular causes, same with urinalysis. A CBC can tell you about renovascular if there's thrombocytopenia, renal causes if there's anemia related to CKD or neoplastic causes. A kidney ultrasound with Doppler is a very high yield test to look for both renovascular, renal, and neoplastic causes, and an echo that can look for causes of the hypertension as well as evidence of end organ damage. And if you do the initial investigations, plus you've taken a good history, you're probably going to catch the most common risk factors or causes of hypertension. If you still don't have any answers, then there's more specific investigations you can do, such as Renan's and Aldo's, head ultrasounds if you're worried about a neurologic cause, calcium, cortisols, renal scans, things like that. Angiography is a tough one, which you usually need to wait till the infants are large enough size for the procedures and the catheters before you can pursue that one. What about management of hypertension? Well, there are specific causes that sometimes need a specific treatment. So obviously coarctation requires a surgical repair. Congenital adrenal hyperplasia requires steroids, which you probably would otherwise not be giving to a hypertensive infant. If it's a drug related, to reduce the drugs, hyperthyroidism, you may need anti-thyroid medications. So certain conditions don't need general antihypertensive, but need a more specific cause or treatment. And then you have to decide if you're dealing with a hypertensive crisis. So that's when you're worried that there's either evidence of end organ damage in terms of neurologic or cardiac consequences, they're in congestive heart failure or they're having seizures, or if you think it's high enough that they are at risk of that, then that's a hypertensive urgency, or whether you're dealing with a neonate where the blood pressure is just floating around the upper limit of what you're comfortable with, whether that's the 95th or 99th percentile, that's a different scenario. But if you're dealing with something that's quite urgent, then there's a list of IV medications that can be given as an infusion and easily titrated so that you can have a very slow and controlled reduction in the blood pressure. So some of the options that we have in North America, nicardipine, labetalol, esmolol, nitroprusside are some of the common choices. There's also some short-acting IV medications you could consider. Hydralazine, labetalol can also be given as a bolus. And then some other short-acting oral medicines like isradipine, nifedipine, clonidine, those are all options. Again, when it comes to routine management of non-urgent hypertension, there's a huge list, includes drugs from all different categories, vasodilators, ACE inhibitors, calcium channel blockers, alpha and beta blockers, central alpha antagonists, diuretics, and be very careful that the doses can be quite different depending on the renal responsiveness and the metabolism of the neonate. So make sure that you're choosing the right dose, because for example, ACE inhibitors are about 1/10 the usual dose you would use in older children. So that's nice to have a nice long table, but what are people actually using? So this is a summary of some of the recent studies looking at what kinds of antihypertensives are being used in the NICU. So vasodilators like hydralazine are very commonly used. Calcium channel blockers like amlodipine are also a common choice. To me, surprisingly, ACE inhibitors were used in 30 to 50% because in general, we're not recommending the use of ACE inhibitors until they're about 44, 46 weeks corrected gestational age due to the importance of the renin-angiotensin system in development. Alpha and beta blockers are a pretty safe choice most of the time, and diuretics can be used for multiple reasons in the NICU. It actually surprised me the most when I was looking through these studies is that in patients diagnosed with hypertension, about 15 to 25% actually didn't receive any antihypertensives at all. And I suppose that shouldn't be surprising with the fact that none of our antihypertensives are approved for use in neonates. And, we don't know what the potential long-term side effects are using them at such a young age. What was also a little bit surprising was that about a third to half actually need multiple agents to control the blood pressure. And in fact, those ended up often being the term infants, the ones that had underlying conditions as a cause of their blood pressure. So maybe that sense that's not as surprising. About following up a bit. Well, very fortunately, regardless of what we do, most of the neonatal hypertension is going to resolve over time. Now, about 40 to 80% that are diagnosed with hypertension in the NICU still need medications at discharge. And in fact, some of the hypertension, especially related to chronic lung disease, could show up in the NICU follow-up. And certain diagnoses may be at an increased risk of developing hypertension over time, such as autosomal recessive polycystic kidney disease, coarctation post-repair. If it ever restenosis, hypertension can develop again. And those little ones with renal vein thrombosis, a lot of them will have their kidneys involute over time. And as that happens, they're at higher risk of having neonatal hypertension develop in infancy. But most cases, about 80% from the NICU, resolve over the first 6 to 12 months of age, regardless of what we do. Keep in mind that the AAP guideline does recommend that children with an underlying risk for hypertension, which includes all of the NICU graduates, should have their blood pressures measured at each clinical encounter from birth. So at NICU follow-up, we'd recommend that they do get their blood pressure checked. Sometimes certain conditions present after being out of the NICU. And this is just my short summary of what I think is going to be the next discussion. Don't forget that there's a lot of neonatal risk factors for future renal and cardiovascular conditions, and the etiology is likely multifactorial with a combination of incomplete nephrogenesis, acute kidney injury that happens in the NICU, and a genetic predisposition. We know that being born premature leads to higher blood pressure in childhood and hypertension and CKD in adulthood. Being born intrauterine growth restricted can lead to hypertension and altered vascular regulation in both children and adults. And the role of postnatal weight gain is a little bit controversial. It seems that if there's a rapid early postnatal weight gain in childhood, that can be associated with hypertension. But by the time you get to adulthood, most of the other cardiovascular risk factors like current adult BMI and things make that association less important. And there's also, we have to remember that a increase or improvement in what is a low weight as a neonate may have adverse consequences on blood pressure, but it may have some benefits for neurocognition. So we have to think about weighing those risks and balance them appropriately. And so I think it's a whirlwind summary of hypertension management in the NICU. I'm happy to answer questions.
Thank you, Dr. Janice, for the excellent presentation. I'm sure there'll be a lot of questions people will want to ask, but we'll take it at the end of the session, and we'll go on to the last talk by Dr. Lakshmi, who's a neonatologist and head and consultant of Department of Neonatology at Mehta's Multi-Speciality Hospitals at Chennai in India. She's also the secretary of the Tamil Nadu National Neonatology Forum and faculty for NRP in India, with a teaching experience over 23 years in the National Board in the MGR Medical University, and has several publications to her credit. Dr. Lakshmi will be talking on preterm birth and its short-term and long-term impact on renal functions.
Thank you, Dr. Uma Ali, for the wonderful introduction. I will share my screen now. Is it visible? And
Yes,
yeah,
Dr.
your
Lakshmi.
screen is visible.
yeah, so let me share it. So thank you. Good morning, good afternoon, good evening, wherever you are. Am I audible? Yeah.
Yes. Yeah.
It's a real great pleasure to be amongst you today. And I think it's a dream come true for Sukanya and I, and we have been planning this excellent conglomeration in neonatal nephrology for quite some time, and we finally did it, and we are very delighted about it, and I'm very happy to be a part of it. Just for in those in other parts of the world, we belong to the Mehta Hospitals, which is in India, which occupies the southern tip of India. And this is our NICU, where I've been attached to this NICU for the past 18 years. And my gratitude and respects to my teacher, my mentor, Dr. R. Shanmugasundaram. I'm one of the most privileged person to be under his guidance for the last 20 to 23 years, and he continues to mentor me, and I'm very grateful for it. Yes, the agenda is for the today I have prepared is a little about the preterm kidneys, some of which have been covered already, about the size, structure and function, because they are the one which are going to dictate how this kidney is going to function as the preterm baby goes into adult. We have to talk a little about the antenatal events and FGR. FGR is fetal growth restriction. Earlier we were calling it as a UGR. And yes, we all talk about the nephron endowment of these preterm and growth restricted baby, which is going to dictate their later life, and few data on follow-up, the studies which have been, and how are we going to address this issue. This is what I had planned for the day. Yeah, as Dr. Namashwayam had already told, an adult kidney, a preterm, a neonatal kidney is not a pediatric kidney is not an adult kidney, like that. More so, a preterm kidney is not a term kidney. They are going to vary a lot on size, weight, volume, structure, and function. This is the timeline of nephrogenesis. And we all know the third trimester is the most active period of fetal nephrogenesis. More than 60% of the nephrons are formed. So from 20 to 34 weeks is the period of nephrogenesis, which goes rapidly. In the last 20 years now, we had started with 28 weekers and now we have come up to 23 weekers. So imagine at what stage of nephrogenesis these babies are going to be. So their nephrogenesis is not going to cease at the time of delivery. It's going to continue, and some studies say it continues for even 40 days postnatally. Yeah. So the length of a preterm kidney, the size of a preterm kidney, as well as the volume of the preterm kidney is highly gestational dependent, and the earlier speaker has also suggested that the kidney length, lower the gestational age, smaller, and as the gestation age progresses from 28 weeks to 36 weeks, we also see multiple studies have shown that the kidney size is going to increase. So when we deliver before 28 weeks, we have a very, very small size kidney. Some of the studies have also shown, because of huge variability in the gestational age they have taken and what age they have assessed the size of the kidney, and how they have compared the size of a preterm kidney, whether they had a controlled term kidney or they did a combination of an extreme low birth weight with a very low birth weight. So multiple studies, and see how inconsistent the results were when they compared the renal size. Some showed a large relative volume in preterm kidney. Some showed a smaller volume in preterm kidney, and some showed no difference. That's mainly because of various different studies showing different gestational age group and the different comparison age group and the different postnatal age group. But one thing was consistent when they compared. See, preterm AGA versus SGA. Preterm SGA is a double-edged sword, or whatever I say. You're adding insult to an injury. Already a preterm kidney. In that, the baby has been growth restricted because of not a very conducive intrauterine environment. And these preterm SGA kidney, they produced consistently smaller kidney length when compared to a preterm AGA kidney, because they already are insulted in utero with apoptosis, and they have not only reduced number, also the length of nephrons are also much lesser when compared to an appropriate age kidney. Having said that, we always tell that the nephron numbers matters the most. More the number of nephrons, more is going to be the size. Sometimes what happens is when these preterm kidney following birth, they have to meet the higher demands of postnatal function, metabolism, growth, everything, and their glomeruli and tubular, they start getting into hypertrophy, and that may contribute to a higher size. The nephron numbers are the same. They are not going to increase, but they enlarge, and because of the extra work they had to do. Anyway, the nephron numbers are much lesser when they are born. Imagine at 25 weeks how less they are when compared to a term birth. But their size may be inconsistent. It may be small or it may be normal as they start functioning postnatally because of their hypertrophic segments. So this is another to know the glomerular generations are highly dependent on the gestational age and also the weight of the baby and also the kidney weight. So lower gestational age, they have more generation, more growth restricted baby again, they are going to have lesser generation. So when you think about nephrogenesis, gestational age matters, the birth weight matters. Even if there is fetal growth restriction, it is going to have a huge impact on your kidney size. And these kidney, when they start to function postnatally, somebody beautifully showed how the kidney migrates, the number of nephron generation, which are much lesser in a preterm, they migrate towards the capsule. As new nephrons are formed, they go towards the capsule. And they found when these preterm kidney, when they start to function postnatally, so almost 18% of them, the structure of them is not very good. Most of them are seen towards the outer cortex, and they are all the newly formed because of the stress of having to work more. They are all poorly vascularized, shrunken units. See how wide the Bowman capsule is, very widened, and the vascular tuft is also very shrunken. And these kidneys are not going to contribute much to your function or GFR, and maybe up to 18% of them may be in such a way. So these preterm kidneys have lesser glomerular endowment, that is, they are not endowed by birth, they are not endowed with adequate number of nephrons, adequately functioning nephrons, but with lesser number, they have to start functioning as soon as they are born, because they are just bombarded with lot of work with the fluids, they have to excrete the drugs, they have to excrete the toxin, and they have to compensate, they have to maintain their homeostasis. So increased filtration per nephron thus occurs as an adaptive response to the nephron loss. So they are lesser endowed with glomerular, but these nephrons are working over time, and that's when eventually when they work over time, it leads to a lot of glomerular changes, sclerosis, decline in their function, and leading to hypertension also. So this was the landmark study in 1990 where Dr. Barker is the first person to say, yes, please don't happy as you send them out of the NICU, these preterms, low birth weight and IUGR. He followed this cohort up to early adulthood, and they found an alarming rise in diabetes, hypertension, coronary artery disease, all the metabolic syndromes occurring by middle age. And this is what incited interest in many of the pediatric nephrologists as well as neonatologists to carefully follow this cohort into adulthood, and made us look at the kidney, which could be an important reason for hypertension in these babies. So when these cohort of babies were followed up, the preterms, the extreme preterm, there are a lot of follow-up studies at 2 years, at 13 to 14 years, and as well as up to 43 years, the studies are available. Very few of them are prospective and most of them are retrospective. And here they followed a 28-week group, followed up prospectively in up till 24 months. Most of them, they do the estimated GFR at 24 months because that is the time you expect the GFR to attain a steady state close to the normal value. And they looked at the primary outcome of the kidney volume, the size, and the estimated GFR. And here they also had a term controls to match, so that how do they perform when compared to their term babies. And the results showed a very lower kidney volume in preterms at 2 years of age. And these children were also not growing very appropriately when compared to their term group and was statistically significant. But the eGFR they calculated was not. I have an important topic. Please, I'll call you back in 10 minutes. And they were also not growing very well during these 2 years, but they found the estimated GFR to be not very significant when compared to their term age group. That is mainly because earlier also it was beautifully highlighted about single nephron hyperfiltration, putting these infants on a trajectory to develop CKD. So by single nephron hyperfiltration, they maintain their eGFR for a while, and then they give up and get into chronic lung disease. This is another beautiful follow-up studies of babies who were less than 35 weeks of age. Again, they chose to do the GFR by 2 years of age. And it is a retrospective study from the case records, and the gestation age they had chosen were less than 34 weeks. And again, they monitored the body weight, height, the GFR, and the creatinine of these babies at 2 years of age. And they found the GFR correlated very strongly with the gestational age at the time of delivery, and also the GFR had a very strong correlation to the birth weight. So lower the gestational age and birth weight, your GFR is not going to be as par as a term baby at even 2 years of age, which is little contrary to the earlier studies. And they also, there are a lot of confounding factors. You just cannot say like gestation age and birth weight. There could be a lot of confounding factor. There could be an associated growth restriction, and there could be drugs used in the NICU where we use frequently indomethacin for a duct closure. And earlier they had even used indomethacin for a preterm labor in the mothers. And sepsis per se may have an impact, and aminoglycoside use may also have an impact. And they eliminated all these risk factors, and when they looked at all these risk factors, it did not have. So sepsis did not contribute, drugs did not contribute, and even your indomethacin use did not contribute to the GFR. But one factor they found is when they looked at the serial creatinine, and the 7th day serial creatinine was much higher in babies who had, they divided the group into 2 groups, those who had a normal GFR and those who had a lower GFR. And they found the 7th day creatinine was much higher in babies who were preterm than babies who were controls. So at 2 years of age, when they looked at the preterm babies who were 34, 10.7% of these babies had a low GFR. By telling low GFR, it was less than 90 ml is what they say. None of them had any abnormal clinical symptoms or abnormal urine examination. All of them were not growing very high. So their anthropometry correlated with their low GFR, but the creatinine was not significantly altered among these groups even at 2 years of age. Then they started looking, it's a beautiful cohort study, a long cohort study, which was a retrospective, and they studied at adolescents, 13 to 14 years of age. How do these babies who are 32 weeks and below, how do they perform at adolescence? And here they are determined to look and compare growth restriction along with prematurity. And they also did a protein load to see if, because earlier studies had shown the GFR may not be very correlative. So they wanted to look at the protein load and see whether GFR is affected or not. So at 13 or 14 years of follow-up, when these children were followed up with their blood pressure, the growth restricted baby on an average had a 4.6 mm higher systolic blood pressure when compared to appropriately grown babies. So again, we have to reiterate prematurity alone, not a factor. More than it, if a growth restriction is there along with prematurity, we have more worries to tackle. And again, following a pre-protein load, you see in the SGA group, the GFR is much lower when compared to the AGA group. At 13 to 14 years, there was not a significant increase in the GFR. This is much more significant in a preterm SGA and the term SGA than an appropriately grown group. So we have data telling that growth restriction is going to matter most, and it is going to affect the GFR following a protein load at 13 to 14 years. These babies may land up with hypertension. And this is the biggest cohort study, which is from Sweden, where they had taken retrospectively from their birth registry. They have robust birth registry. They had picked up all babies who were born below 37 weeks, and they had taken a chronic kidney disease registry, and they had picked up all, followed up all these babies, and they have found out which of these babies had landed up in chronic kidney disease as defined by your international classification. Of course, there were a lot of confounders. By it could be an environmental genetic factors, and they have looked into all this, and in their data, if the general incidence of CKD was 4.95, the alarming increase, almost doubling in preterms and early terms of a baby at 0 to 40 years. You see, up till 40 years, they had followed millions of babies, and they had followed all these babies who had had CKD. And another alarming data, if this preterm had a history of acute kidney injury in the neonatal period, their CKD incidence is much, much higher. So this is varying gestational age, extreme preterm to full term, and extreme preterm had almost threefold rise as compared to late preterm who had twofold, and an early term who had still early term had 1.3-fold. So lower the gestational age, they concluded, higher is the risk of CKD into adulthood. And yes, they did adjust for the confounders. And this is the forest plot to look at the hazard ratio of varying gestational age. And they found the hazard ratio of almost 3 for early preterm babies or extreme preterm baby when they reach into adulthood. So this is something we have to keep it in our mind. As compared to the earlier studies where they looked at the kidney size and they found inconsistent results, when they compared the kidney size in long term at various age groups from 5 to 6 years to 20 years, consistently they found these babies to have a very, very small kidney. And this is a very consistent across many studies which have been listed. So preterm babies who are extremely preterm and growth restricted baby are going to have a very small kidney as they grow, which may not be evident at the time of birth, but eventually they may get into very small kidney with reduced GFR and chronic kidney disease. And this is the final meta-analysis which had come out very recently. And they had looked at all studies who were reporting outcome at various age group for all preterm babies and small for gestational age baby. And they had also took the studies who had appropriate controls and at least 2 years beyond. If they had given some outcome, I think all these studies, they have taken 27 eligible articles, they have robustly looked into the data for the quality of the studies, the heterogeneity, the bias, and they had looked at various issues in the follow-up like that. How did they monitor the renal function test? Is it through their creatinine, cystatin C? Did they measure their renal plasma flow, or is it urinary albumin and creatinine ratio, the kidney volume, the ambulatory BP? So all this data, they were beautifully collected, and these were the results, and none of the markers were very significantly different in babies who are preterm when compared to term when they were followed up beyond 24, which included creatinine and other things. But they did find out that 2 studies had shown a significantly lower eGFR, and 2 studies did not show a significantly lower estimated GFR, but still the overall effect was much towards low GFR. And the urinary albumin creatinine ratio, which they had done, had contributed much in this follow-up population. And this is their forest plot, which were showing the kidney length, the volume, everything was much lower during follow-up in the babies who were preterm as against the full-term controls. And blood pressure, be it an ambulatory blood pressure monitoring or a single value blood pressure monitoring, be it a systolic blood pressure or a diastolic blood pressure, be it monitored in the daytime or in the nighttime, they were all significantly higher in babies who were preterm and babies who were small and preterm as against term babies. This is something which we have to keep on monitoring. But again, they reiterated serum creatinine, which we usually think as a marker of your kidney function, has not been significant across the age group. So we all know growth restriction, preterm, low birth weight are detrimental to the in utero as well as the postnatal kidney. They reduce your nephron endowment, as a result of which single nephron glomerular hypertrophy will come, and this makes them vulnerable to long-term disease. So your problem starts antenatally. The right kind of nutrition for the mother is very, very important for the nephron growth, and mother should not get into hypertension. Surveillance should be there. She should not get into diabetes mellitus and other disorders which can influence your placenta and also affect the fetal growth, where if the vasculitis or vasculopathy is significant, you get into small for gestational age, and these risk factor also lands up in a preterm delivery, and that is when the problem starts. So antenatal in utero life of the fetus surveillance should be augmented. A word about antenatal steroids. Many of them have been giving antenatal steroid. Way back, antenatal steroid increases the maturation of the kidney, but it hardly does anything to the nephron number or anything. So it just accelerates the maturity, like how it does for the lung. It accelerates the surfactant maturation release, but nothing much has been done. The structure altered or the structure stopped maturation is there. And this leads to impaired nephrogenesis. Here we get into a preterm delivery, and once a baby is delivered, in utero, the baby is in a fetal hypoxic environment. When he comes out, even in the normal room air, he is coming to a relative hyperoxic environment, and where we give a lot of postnatal medication. And again, I'm telling you, your nephrogenesis is not stopping. If the baby is delivered before 34 weeks, it is ongoing. And the neonatal nutrition should be addressed, because extrauterine growth restriction when these babies are not growing very well is again going to give an insult to your kidney. So the nephron number is lower, the injured glomerular tubular, all this makes them very vulnerable to their renal problems. So how do we address it? Yes, we have to prevent prematurity, and fetal growth restriction surveillance should be very much intensified. The maternal nutrition should be addressed, the maternal surveillance, so that she doesn't get into an adverse in utero fetal environment, and promptly treat them. And you manage the Dopplers, watch the Dopplers, and deliver these babies at the appropriate time so that they are not insulted for a long time in utero. And yes, we have to avoid nephrotoxic. Nowadays, we are not using indomethacin for preterm labor, and AC inhibitors has also been cut down drastically. And yes, antenatal corticosteroid does help in maturing a kidney to some extent, but whatever happened at the time of delivery has happened. So with all this, the nephron endowment, which is very low at birth, lot of things happening. So
Dr. Lakshmi, we are running short of time. So
1 minute.
Can you sum up in a minute?
Yes, the last message.
Okay.
So we avoid hypoxia and hyperoxia. We avoid the hemodynamic fluctuation. We avoid sepsis. We keep a close watch on nephrotoxic drugs. Give a good renal surveillance, adequate nutrition so that they grow well, and avoid EUGR. We have to treat the baby. We are not treating the organ. And so with this, I conclude they are at risk for long-term morbidity, more so if they are with IUGR. Lower the gestational age, higher is the risk. Lower is the centile, higher is the risk. Course in the NICU really matters, and you have to prevent AKI, and they may not show up with symptoms or abnormal urine. It is for you to follow them up till their adulthood and pick them up early if they are going in the trajectory of chronic kidney disease. Again, your serum creatinine may not be enough. So we may have to do an ultrasound kidney, anthropometry monitoring, ambulatory BP monitoring, and GFR also may be calculated to catch them early. Never stop monitoring. We have to follow them up to adulthood. That is a very strong message. Having said that, it is not easy to call a normally growing baby cohort to come back and get these tests done. That's a big challenge we face. And with this, I immensely thank my team at Mehta Children Hospital, our neonatal intensive care unit team, comprising of our residents, our mentor, Dr. Shanmuga Sundaram, and the nurses for giving such a wonderful result to all these extreme low birth weight babies. Thank you, one and all. Sorry for exceeding the time.
Thank you so much for the excellent talk on the insights. I think since I will go through the questions, there are many questions on the question box. And I'll first address the questions to Dr. Olivia. I think some of the questions which are not covered or were covered in your talk, I'm excluding. One question which was asked was about NSAIDs. When should we add NSAIDs? And should we continue the NSAIDs if they're giving a good result, even if there is some drop in GFR?
Yes, that's a good question. So what we recommend in the guideline is if you saw some improvement with ACE inhibitors, but there is still massive proteinuria and NS, we recommend to give a try of NSAIDs dosed incrementally and to test for the response. So if with that treatment you see a further improvement in proteinuria, albuminemia and edema, then you can go on with this drug, even if there is a small raise in creatinine, and we agreed that a raise of 15 to 20% is acceptable. But if you don't see any improvement after 2 to 4 weeks, then you should stop the treatment, not to be harmful.
Related question is, can we go to supranormal levels of ACE inhibitors to control proteinuria?
So we do not really recommend supra high dose because usually, the children who will respond to standard doses. And then in the Finnish patients with very severe variants and severe nephrotic syndromes, they would not respond to any dose. So in our experience, there is no need to give supra doses.
Okay. There was one interesting question about vitamin D supplementation in these children, and that it would remain low because of the loss in vitamin D binding protein. So when should we supplement and what should be our goal?
Yes, so that's a very good question, because as you said, the levels cannot be trusted, and it's usually very difficult to reach normal values of 25 OH vitamin D in these kids. So usually you have to give at least what is recommended for other children, and be sure that the ionized calcium and PTH are within normal ranges. That's what we wrote in the manuscript.
Okay, thank you. And there was one important question of, I think, anticoagulation, whether we should use an all, and what is your choice of anticoagulant that we should use?
Yeah, so we do not recommend anticoagulation in all children, because the ones who are doing well with no central venous line and being at home with no important edema, they should be spared this drug. But as we said, if there is a high risk of thrombosis, such as in kids with hypovolemia or hemodynamic instability, or the kids who need a central venous line for albumin infusions, or those with a personal history of thrombosis, then we recommend anticoagulation. Once again, there is no good evidence to recommend any of the agents. The most widely used, especially in the Finnish cohorts, is the antivitamin K warfarin. The problem with this drug is that it's linked to albumin. So if you give albumin infusion, it can be the INR can vary widely, but you have to check the INR at the same time every day under the same condition, and the drug can be used safely like that. The other thing I want to say about that is that low molecular weight heparin needs a good antithrombin 3 level to be active. So if you use low molecular weight heparin, then be sure that your antithrombin 3 level is correct. Otherwise, you have to give some.
Is there any role for using plasma in some very young?
Well, that's a good question of neonatologist. I'm not aware of using plasma in these kids. I guess that if there are other indications for plasma, such as severe septic shock or so on, it can be used, but otherwise everybody uses albumin.
Yeah. One last question for you, that if the child has tested CMV positive, should we still go ahead with genetic testing?
Yes, that's a very good one. You know, the congenital nephrotic syndrome due to infections are very, very rare. And there are some reported cases of coincidental occurrence of congenital infection and a genetic form of congenital nephrotic syndrome. So we recommend to perform the genetic testing in all children, even if we have a congenital infection.
Okay, thank you so much for your answers.
Thank you very much for the invitation.
Yeah. Dr. Janice, there are some interesting questions for you. One is, how frequently do you see hypertensive crisis in neonates?
Yeah, I don't think I've ever seen a study actually giving a rate. If we think that regular neonatal hypertension is 1 to 2%, it's probably 1/100th of that. I would say that in our unit, where we have a 60-bed NICU, we probably see it once or twice a year. And the very interesting thing about that is they often will present with decompensated heart failure. They're actually hypotensive. And then as they treat the cardiac contractility, it kind of unmasks the hypertension. And then you realize that actually the hypertension was probably the cause of the cardiac issue rather than a primary cardiac issue. So it's not common, and it can be a tricky presentation. You know, it's either that or it's some dramatic increase in blood pressure suddenly relation to an umbilical line and a thrombosis or something like that. So it's not a common problem.
And what would be your choice of drug when we have to treat a hypertensive crisis from all the list which you showed us?
Yeah, I guess my preference more recently has been to use nicardipine, an IV calcium channel blocker. Only thing is you have to be careful. It's better with a central line. It's not good if it extravasates, but it's a pretty nice short-acting one. With things like nitroprusside, you have to worry about the buildup of the cyanide kind of metabolites if you use it for too long, especially in neonates with poor renal function. Labetalol has been a stable one as well for the IV management that we use.
And for your regular management of hypertension beyond the crisis, what's your drug of choice?
If it's related to, if I suspect it's related to chronic lung disease, I'll use the diuretic. And in other routine cases, I'll often use something like a calcium channel blocker just because there's no need for blood work monitoring. It's generally has low side effect profile.
Another interesting question is, when would you consider doing renin-aldosterone levels when you're seeing hypertension in these babies? And are these reference ranges different for preterms, full-term babies?
I think the question, the person asking the question must know that those references are actually terrible. If you pull the original references, they're based on small number of infants, and the values and normal ranges depend on if they're higher if you're preterm. They depend on what day of life you are. They depend on what mode of delivery you used. So they're not great. And in fact, I think people like to order them trying to catch a high renin and aldo, but really they're meant to catch the suppressed levels in monogenic forms of hypertension. So I'm not a huge user of those values, and mostly I'm going to do it if I'm trying to catch a monogenic form where you have electrolyte abnormalities, and I'm trying to find them that they're suppressed. I'm not usually checking them to catch them when they're high.
And before you start treating a neonate, would it be the same recommendations that we take 3 readings and if it's all above 95th centile, we start treating?
Yeah, we don't actually know how many have to be high to diagnose it. Sometimes there's certain things going on with an infant for a day or for a few hours that you can kind of just watch and see. So I don't know that we actually know how many have to be high. I would say if it's, the majority of readings are above the 95th percentile for a day, as long as we're not in the hypertensive crisis range, then that might be a time where you diagnose hypertension and look into it more so.
And one last question is, when we follow these children in the OPD for till the age of 2 or 3, what would be the best method of monitoring the blood pressure in the OPD situation?
So as those of you who do the follow-up know, that it's a challenging age to get an accurate blood pressure. So once they're out of the NICU and they're less than a year of age, we still say that the oscillometric method can be used. And that's what we use to compare to the normal values. And again, it's a good screening tool. We can use it for screening after a year of age, but if it's abnormal, then we're meant to do it manually. Now, at that age, it can be very hard. Sometimes I find that either I'm just trying to get a palpation for systolic pressure because the child is so wiggly. But the other thing that I'll often do is bring them into our medical day unit, where I have them tell the parents to bring a bunch of toys and whatever, and foods and snacks, and have them sit there for about 3 hours and have the nurses repeatedly do oscillometric pressures, and they'll get used to the cuff over time. And that usually by the end of that, you've got some really much more accurate readings that you can decide whether they are hypertensive or not. So it takes some tricks to get often a good blood pressure at that age.
I think, thank you so much. I think most of the questions are covered, and the remaining, I think, were covered in the talk. So I'd like to thank you very much for your answers as well as your lovely talk.
Thank you. Thank you for inviting me.
Yeah, thank you. And I hand over the session to the organizers.
Thank you very much, Dr. Uma, and all the speakers today. We know we have exceeded the time much beyond what we planned, but I think we all had an interactive and excellent session today. We also have a array of wonderful sessions tomorrow on neurology, dialysis, and nutrition. So please do join us tomorrow. We promise we'll stay in this with the time. So I appreciate all the faculty who have joined today and all the delegates for joining in. Have a lovely day ahead. Thank you. Thank you.